often impact bleeding and fertility more, potential complications in treatment, options, medication, minimally invasive procedures like embolization or surgery, size, number, and growth rate also play key roles. So note, fibroids are almost always benign. Consult a gynecologist for personalized evaluation, often involving ultrasound or MRI for accurate classification. Symptoms may vary widely. Many people have fibroids and no issues at all. So, ladies and gentlemen, this brings us to the end of our presentation on fibroids. I hope you understood the different types of fibroids that we have outlined or summarized. Don't forget to share this educational content with your colleagues and also subscribe for more educational lectures on this channel, on our YouTube channel. Thank you very much. Hello everyone and welcome. So I feel the best way of learning is to repeat. Repetition is the best way of learning. So in this presentation, I am going to give a compilation of different or various uterine pathologies. So we are going to have a compilation of all the pelvic pathologies. So we are going to do it stage-wise because there are too many, we can't do them all in a single presentation. So we are going to sub-categorize these different pathologies. So let's start to discuss on uterine fibroids and their different manifestations and their sonographic appearances so that you can have an appreciation of the different types of fibroid that you can come across when you're doing your ultrasound studies. So here is your uterus, and then we have got different types of fibroids with different locations. So we can have what are called subserosal fibroids. So this one, the subserosa, so it dents on the serosa there. Then we can also have got a pedunculated submucosal fibroid. So a pedunculated fibroid can be in the inside of the uterus, in the intracavitary, or it can attach itself to the walls of the uterus. That would be outside. So we also have got a submucosal fibroid. So that's the one that dents the endometrium like that. So that's a submucosal fibroid. Then you can also have the one that is found within the myometrium. Now this is called the intramural fibroid. So the one that dents the perimetrium like this is the subserosal fibroid. We also have another fibroid that is very difficult to distinct, that can stretch all the way from the subserosal part to the endometrial cavity there, like that, a big one. That's called a transmural fibroid. So here are different types of fibroids that we have. So we have got a very giant fibroid here. So you can see there's a thin margin between it and the rest of the walls of the uterus, but you can see that it's well outlined. If you follow this, you can see that it's a well outlined fibroid like that. And inside, you can see that it is heterogeneous. It is heterogeneous. When we say heterogeneous, we say that the tissue of the fibroid, they are not uniform. So some, they are bright areas here, there are darker areas there. But in terms of the composition, it's almost having the same echogenicity with the rest of the uterus like that. So this fibroid is almost isoechoic. So if you look at the back of this fibroid there, you can see that there is posterior enhancement, the brightness that we are having there. That is what is called the posterior enhancement. So a lesion or a mass that enhances posteriorly mostly is a sign that it's a benign mass. So this is a fibroid. It's well outlined. It's not invading the surrounding tissues and is having a mass effect. You can see this part of the uterus there is sort of pushed up, so that this is a mass effect of the fibroid. So this is one type of a fibroid that we have there. If we move here, that's our uterus there on transvaginal. So you can see the cervix there. There's a small cyst there. That's called the nabothene cyst in the cervix there. So that's the endometrium. Then if you see here, there are multiple areas there. There are multiple areas there which are hypoechoic as compared to the rest of the uterus. But these ones can be confusing. So some people, they feel that, or they would think that these are fibroids. But to me, these ones are not fibroids. These are not fibroids. They can also be tiny fibroids like this, which are punctured like that. They can be fibroids as well. But to me, look here, you can see here, there's a cesarean niche there, meaning to say that this patient had a cesarean section. That's a cesarean scar there. And if you look at the endometrium closely, it is very much indistinct. It's very here, it sort of disappears, the endometrium there, and then we have these ones. So according to me, this is diffuse adenomyosis. This is diffuse adenomyosis. So you can have fibroids which are small, but these are not fibroids, but diffuse adenomyosis. So I need you to appreciate the sonographic appearance of those small tiny fibroids there. But they are not fibroids in this case because this patient has a history of a cesarean section and the endometrium is indistinct there, sort of disappearing. So here you cannot differentiate the myometrium from the endometrium here. So this is diffuse adenomyosis. We are going to discuss about adenomyosis in due course when we will be dealing with endometriosis. So now, again, here you can see that we are having a fibroid there, this lesion there. It has got bright margins. So this is in keeping with a calcifying fibroid. So this fibroid is sort of calcified. So if you look at the uterus well here, the uterus itself has got issues. It looks like it's also atrophic because if you look at it, these areas, they are very bright like that. And then there is another lesion, a mass here, that is also appearing like another fibroid there. And you also got another fibroid there with a cystic portion there, which is showing signs of degeneration. So mostly after uterine embolization, you can have fibroids which start to die like this, or if they fail to have enough blood supply, they will start to die like that, and then you can see them calcifying or dying like that. So here you can see here there's a very large fibroid that we are seeing there. That's a very huge fibroid there. So if you look closely at the fibroid itself, it has got a different echogenicities. This area, it looks like another fibroid within a bigger fibroid. So it has got different, it's heterogeneous, but it's well outlined. As you can see that you can trace it nicely, and there is also posterior enhancement on the posterior aspect like that. So that's a fibroid, huge as it were. So you can see that it's having a mass effect on much of the uterus, and it's denting the endometrium. So this type of a fibroid that is huge like that and stretching all the way from around from the serosa to the endometrium is called a transmural fibroid. That's a transmural fibroid. So again, we have got a giant fibroid here. You can see this one is well outlined. This one is a very much well outlined fibroid, and you can see that's our uterus there. That's another transmural fibroid. So it's having a mass effect on the surrounding structures. So these fibroids can really grow very big, even the size of your head. So they can be very big, and at times they can be confused with a pregnancy because the belly will bulge as if someone is also pregnant. So again, if you look here, you can see that's the uterus. Then this is the cervix. You can the cervical canal there. Then you can see this is the body of the uterus there, and you've got another huge fibroid, the Venetian blinds. So these lines that you are seeing here, this is what we call the Venetian blinds. So this is a fibroid, the whole of that. It's a well outlined fibroid. So you can see the problem with fibroids, some of them, they will have almost the same echogenicity with the rest of the uterus. So they are sort of isoechoic, but if you look closely now, you can see that it's a mass. It's distinct from the rest of the mass, from the rest of the uterus, as you can see there. So that's another type of a transmural fibroid. So let's have a look here. You can see the uterus there, and you can see there is a fibroid there that is attached to this uterus. So this is a huge pedunculated fibroid. So there's a stalk, there's a connection between the fibroid itself and the uterus. So such type of fibroids are called pedunculated fibroids. These ones, mostly they cause excruciating pain. Why? Because at the stalk here, they can twist because there's a small narrow stalk that connects the two. So it can, because the uterus is also mobile, and the intestines and all that, so this thing can move and twist and cause sort of toes. When it happens, you can have excruciating pain from a pedunculated fibroid. So look closely here. You can see here there are multiple lesions, multiple lesions, multiple. So all of these ones. So these are multiple uterine fibroids. So this is one of the problems in gynecology, because imagine if a gynecologist is going to do myomectomy to remove all these fibroids, they have to cut all these pockets like that, all those pockets. So these ones, they are very complicated to manage. At times, the only remedy could be a total hysterectomy where they remove the whole uterus. Okay, because you can see they are very diffuse, multiple uterine fibroids. So look here, that's our uterus there. You can see here there's a fibroid there, and this is the canal there. That is the canal, that's the body of the uterus. So you can see here this is a subserosal fibroid. So fortunately, this type of a fibroid, you can easily see it. Why? Because it is slightly hypoechoic as compared to the rest of the uterus. So this is hypoechoic. So this is a subserosal fibroid. So this is another fibroid there. You can see that there's peripheral vascularity that you're seeing there. There's peripheral vascularity. So that's this one. So at times when you see blood flow inside a fibroid, it will mean that that fibroid is transformed into cancer. So at times fibroids can transform and become cancerous. So you must be on the lookout for that. So when you're doing an ultrasound scan, then you see a fibroid that has got internal vascularity or blood supply, you must query cancerous transformation. Do not just ignore that and comment it as a normal fibroid, because the gynecologist can just try to take it out when it's a cancer. So, the management of cancer is very different from these benign lesions. So again, if you look here, the uterus, you can see nicely here, we do have got a fibroid. So this one again is a subserosal fibroid, because you can see it's indenting the serosa of the uterus. So this one is the endometrial lining. So you can see going all the way, connecting the cervix there to the rest of the uterus. So there we are. We have got a subserosal fibroid around the isthmus of the uterus there. So here we have this is a fibroid that is attached to the rest of the uterus by a stalk again. So I've spoken about this. This is what is called a pedunculated fibroid. It's held by a stalk. So that's a pedunculated fibroid. So again, here you can see this is another fibroid. So this is another fibroid there. So you can see all of that is a fibroid. So you must learn to appreciate and understand anatomy using different machines, because some machines have got a very good resolution, but some they don't have so good resolution. So you must be conversant using high-end machines and using the old machines, so that if you switch departments, you can still be competent in using these old machines. So you see here, this is another fibroid that is squarely masquerading. It's masquerading as deep. So there we have it. So this one at times it is very difficult to distinguish from a polyp, but you can see also that it's attached through a stalk here. If you use color mapping, so you see this type of a fibroid now, because attached by a stalk, this is a pedunculated fibroid, an intracavitary peduncular fibroid. I said some peduncular fibroids, they will attach themselves on the walls of the uterus outside, not inside. So this is an intracavitary pedunculated fibroid. So, but if you see such, I urge you to give a differential as well of a polyp. That can be a polypoid mass as well. So again, this is another fibroid there. You can say it's a giant fibroid. Okay, the mass effect of the fibroid and the mass effect of the fibroid. So it is this mass effect. You can see that it's compressing the cervix there. It is this mass effect of the fibroids which normally causes infertility, or it can push and cause an ectopic pregnancy. So those are some of the dangers of trying to conceive when you have got fibroids before they are managed. Either the fibroid will compete for space with the incoming baby and cause a miscarriage, or it can block fertilization totally by blocking sperm movement, and then that can cause infertility. So these ones are going concern in gynecological practice. So this is the same type of fibroids again, the different types of fibroids that I spoke of. So you can see a giant fibroid there in the cavitary fibroid, the second endocavitary fibroid again. So that's another type of a pedunculated fibroid that is in the endometrial cavity. So here again we see there is an indistinctive mass there that is in the attached itself to the fibroid in the. So you can see here it's very difficult for you to distinguish this mass from the rest of the uterus. So this you have to be careful, because they're also seeing the Venetian blinds, the Venetian blinds, the Venetian blinds. So this thing can be it can be a fibroid or differentially depending on the history, and if you do a TVS nicely, you will see it better. So this one can also be focal posterior myometrium adenomyosis. Adenomyosis can also appear like that, and then this will be an adenomyoma instead of a fibroid. But because of the way it is well outlined like that, provisionally it looks more like a fibroid. So those are the things that you have to be careful when you're writing your reports. It's a fibroid, give also a differential of focal adenomyosis posteriorly. Okay, so here now we have got calcified fibroids again. This is a calcified fibroid there. I've spoken about the calcified fibroids, and I've spoken about this case before. So you look at this other one. This is a calcified fibroid. So a calcified fibroid can masquerade as the head of a fetus. Look at it closely, so you can feel that this is the head of a fetus. So you must be very careful when you're doing this gynecological ultrasound examinations. So how then do you differentiate a fibroid from the head of a fetus? One, the history of the patient, the pregnancy test. At the same time, you can't have a head without other fetal parts. So this is an isolated mass that is presenting there in the uterus, but there are no other parts to confirm that it's a fetus. So this is a fibroid with a calcified rim. So you see the rim is calcified, and then you can see the endometrial cavity there. Again, you are seeing this tiny, small calcified fibroid. So this is a tiny calcified fibroid. So also depending on the history, you must be very careful, because these can be gossipy bombers or texalomas, which are foreign bodies prior to other C-sections or other operations, that laparoscopic procedures that were done. So a foreign body can also present the same, but a calcified fibroid can also present the same. So those are the things now where you need to give differentials depending on the history, that you are seeing a calcified lesion in the uterus measuring this much by that much. So provisionally, that can be a calcified fibroid. Differentially, it can be a foreign body. So if they are retained products like cottons and all that during operations, you can also see them like that, or what we call textalomas or gossipybomas. So here you have got a unique type of a fibroid. So what we have here is a fibroid, again appearing like the head of fetus, but interestingly inside you can see that there are cystic spaces, there's some fluid collection. So this is what we now call a degenerating fibroid. So when a fibroid does not have enough blood supply, part of the central spaces or part of the fibroid start to undergo infarction. So this is an infarction. So it's part of necrotization. So it's dying. So when it dies, it just start to form the fluid like that. So this is a degenerating fibroid or degenerative fibroid. Again, you've got a nice calcified fibroid there that I said you must not just ignore and don't give a differential of a foreign body depending on the history of the patient. So you can see there it is, and then also these adenomyosis within this type of uterus. We'll discuss about endometriosis in the preceding lectures. So again here, look nicely here, we do have got a fibroid there, but the uterus, you can see that the uterus is here. So somehow it's in contact with the uterus, but they might not be directly feeding off this from the uterus. So once this fibroid detaches itself or is no longer getting feeding from the uterus, it is now called a wandering fibroid, what we call a parasitic leiomyoma. It's now a parasite. So it's now living independent of the parent organ, which is the uterus where it originally originated from. So if it can detach and then give blood supply from the mesentery, from the intestines, in the surrounding tissue, it becomes a parasite. So here you can see this is a fibroid that is existing in isolation. So this one is a parasitic myoma, or it's a wandering fibroid. So you can see these ones, you can even see them up closer to the kidneys, or in the rest of the stomach you can see this type of fibroids. So again, you can see here, this is a very giant fibroid there, and you can see the uterus there, you can see the endometrial lining there, you can see that there is a distinction between the two. So this is again a wandering fibroid or a parasitic leiomyoma, because it has lost its connection to the rest of the uterus. So you can see again here we have got an endocavitary fibroid there. So that's an endocavitary fibroid there. So you see the challenges of these endocavitary fibroids, because it's seated in the endometrial cavity where implantation is supposed to happen. So this is blocked implantation. So this patient is most likely going to be very much infertile because of this fibroid that is found its comfort there. Ladies and gentlemen, I've tried to give you a diverse range of how variable fibroids or myomas appear like on ultrasound. So I hope we are going to put flesh to the skeleton, read as much as possible, refer to different texts, and also see how other fibroids appear like. Also, departments, try to check the type of fibroids, share the findings with your colleagues, and discuss until everything is at your fingertips. I thank you so much. We'll meet again in the next lecture as we continue building up our database of a compilation of these fibroids and other pelvic pathologies. So that will become our database, where we have a bank of pathologies. A bank of pathologies makes you a better practitioner. Thank you very much. Hello and welcome. So in this presentation, I'm going to discuss about one of the going concern of most pregnant women. So let's talk about uterine contractions, the so-called Braxton Hicks contractions. So I also have got a case report that I did. I will show you the ultrasound images on how Braxton Hicks contractions appear like sonographically. So the Braxton Hicks contraction, also called the false labor or practice contractions. So here they are also called practice contractions or false labor. These ones, they are irregular, sporadic tightening of the uterus that occur during pregnancy. They help prepare the body for labor by toning the uterine muscles and promoting blood flow to the placenta, but they do not cause cervical dilation or lead to birth. So this is the most fundamental part of this presentation. So you ought to know that they don't cause cervical dilation or cause lead to birth. So most women, they feel like they are going to labor when they do have got these Braxton Hicks contractions. So the question is, when do they occur? When do they occur? Can start as early as the second trimester, around 20 weeks. So provisionally, we are saying that around 20 weeks, you can start to feel the Braxton Hicks contractions. But most common and noticeable in the third trimester. So the third trimester is when they are most prominent. They become more frequent and intense closer to due date, sometimes called forced labor at that stage. So we are saying that towards birth, you can experience the forced labor. This is forced labor now, and most people, they do panic during this period, thinking that they are going to have a miscarriage or they are already in labor. So what do they feel like? A tightening or hardening of the abdomen, often described as the belly becoming firm or pointy. So the belly can become firm or pointy due to the contractions, mild menstrual-like cramps or general discomfort, usually more uncomfortable than painful, though varies. The intensity varies. So we are saying that you can feel mild contractions, you can be uncomfortable, but the intensity can vary. At times you can feel the pain. You can typically talk or walk through them. They often start at the top of the uterus and spread downwards. They last usually from 30 to 60 seconds, sometimes up to 2 minutes. So there are variations in terms of the duration in which they will be happening. So now, here is a sonographic case that I did at our department. So you can see here what we have. That's the uterus there, and you can see there's the amniotic fluid there, and you have got our placenta there in the posterior upper segment. This is the placenta that is bright there, but at the back you can see there is this other mass that you are seeing there. Let me show it nicely. So this is the mass that I'm talking about. So this can provisionally masquerade as a fibroid, but this is not a fibroid. This is not a fibroid. So if you just rush through your scan, you can have an illusion that this is a fibroid, and then you can report it like that. So look, after some minutes, I read the sonar, and you can see here the placenta there, and on the posterior part or in the retroplacental space, the contraction, the Braxton contraction is gone. It has disappeared, so it's now smooth. So you can see what we have here. It's only the blood vessels in the retroplacental space. So the retroplacental space the mass is gone. So you must be aware of these when you're doing an ultrasound scan. Don't report them as masses or other lesions. That is one of the pitfalls when you're doing obstetric ultrasound, especially in the third trimester. when the Braxton Hicks contractions also happen in the lower segment, you can think that it's cervical funneling, and then you think that the cervix is opening. Yet is the Braxton Hicks contractions. So now, how do we write a simple report on Braxton Hicks contractions? So the patient name, the gestational age, 34 weeks, 2 days, then the date of birth, 18/07/1990. Then you also give the date of examination, 26/06/2026. Then you also have to give the name of the referring clinician, the indication, evaluation of uterine contractions to rule out preterm labor. So this is how we fundamentally write a simple report. This is how we do the report. This is just a simple report. When someone is having the Braxton Hicks contractions. So here we go. Uterine activity, multiple irregular low amplitude uterine contractions noted during the examination. Contractions are sporadic, non-rhythmic, and do not show progressive pattern. So cervical assessment, transvaginal ultrasound shows closed long cervix with no evidence of shortening or funneling. Cervical length measures 3.8 centimeters. No cervical changes observed. So it is very, very critical when someone is having these contractions to also assess the cervix to rule out a miscarriage, ongoing miscarriage, or cervical opening or incompetence. So the fetal assessment is also prudent and critical when someone is having these contractions. In this report, I will just put a little bit of detail because this is not a report for the pregnancy itself, but I just need to highlight the value or the importance, the relevance of the contraction of the uterus. So fetal assessment, fetal heart rate, normal baseline 145 beats per minute, reactive category 1 tracing. So fetal movements, active and appropriate for gestational age. So the amniotic fluid index, 12.4 centimeters. Estimated fetal weight, 2.450 grams, appropriate for gestational age. Placental fundal, posterior grade 2, no evidence of the abruption. So don't worry about this report. This is I just want to highlight to you the information that you have to put in your sample report when you are doing reporting for a possible Braxton Hicks contractions. So in our case, the placenta was in the posterior upper segment. So this is just a simple report. So don't take that into mind a lot. So this is just a simple report. Okay. The impression now that we have. So irregular uterine contractions consistent with Braxton Hicks contractions, physiological practice contractions. So this is very important. You must know that the Braxton Hicks contractions are a physiological practice contractions. They are not pathological. They are not pathological. No sonographic evidence of preterm labor, reassuring fetal status. So what are some of the recommendations that are given to a patient that is having Braxton Hicks contractions? Hydration and rest, continuous fetal movement monitoring, return for further evaluation if contractions become irregular, painful, or are associated with bleeding, fluid leakage, or decreased fetal movement. So a follow-up with obstetric provider is scheduled is also recommended. So ladies and gentlemen, this is one of the going concern in every normal pregnancy. Braxton Hicks contractions, during the prenatal stage, the ladies must be educated about this one so that they are aware that they do exist. And then, if they are so intense, they also have to seek advice from their referring clinicians. Thank you so much. I hope you are doing very well and you are catching up on every post that we are putting up. If there are other recommendations, anything that you need us to discuss, please just jot that in the comment section and then we will address that accordingly. Thank you so much. Don't forget to subscribe to our channel and share the link to your colleagues, the friends, and other pregnant women. Thank you so much. Hello, good people, and how are you? So now, let's discuss the answers to our ultrasound quiz 2 gynecological ultrasound. So I will give you answers and explanations to the questions that I gave you. So let's start with number 1. So question 1, we have this pathology there. So you can see we've got multiple cysts there in the cervix. So this is our uterus there. So what is this? A ovarian cyst. So this is not an ovary, this is the cervix. You can see the endometrial cavity is continuous with the endocervix there. They are continuous. So definitely this is not ovarian. So ovarian torsion, again I say this is not the ovary, so these are wrong. Hydrosalpinx, the pathology that affects the fallopian tube, so definitely that's not. So these are Nabotian cysts. So these are Nabotian cysts. So the cysts that occur in the cervix are what are called Nabotian cysts. If the same cysts occur in the vagina, now they are now called the Bartholin cyst. They are called the Bartholin cyst. So here we've got question number 2. What pathology is presenting here? So you can see here the uterus is very thick. It's very thick there, like this, and you can see the Venetian blinds that we have. So we've got focal thickening of the posterior aspect of the uterus. So what is it? Is it a subserosal fibroid? No, that's not a fibroid, though it masquerade is one. Submucosal fibroid? No, that's not. Parasitic leiomyoma? No, definitely that's not. So this is adenomyosis. So this is one of the manifestations of adenomyosis. It can manifest as a focal thickening like that. Mostly it affects the posterior aspect of the myometrium. So this is focal adenomyosis, and you can see it with the Venetian blind. So these hypoechoic lines that are appearing like streaks of shadows like that, this is what we call the Venetian blinds, which is one of the sonographic features of adenomyosis. Question number 3. So we have got the uterus there, and you can see the rest of the uterus appear normal. This is the endometrium. Then you've got this cystic collection there, and you can see here it's still closed. Then we've got our cervix there. So what is this? Uterine rupture. Definitely the uterus not ruptured, because you can see there is preserved tissue of the myometrium and the perimetrium here. There's no communication on the bladder there, so it's not a rupture. Uterine cyst, definitely this is not. This is on the isthmus of the uterus, so it is not a uterine cyst. It's not a cyst. It's not a uterine cyst. So Nabotian cyst. So this one is not a cyst, because you can see the configuration, how it is presenting, like it's elongated like that. So this is definitely not a cyst. A cyst is supposed to be well outlined, circular in configuration, like that. So this is uterine dehiscence, yes. So after a cesarean section, the portion that they cut, there can be separation of the myometrial tissue. This is what we then call uterine dehiscence. So this is a sonographic sign of uterine dehiscence. So if it's just mild, it is called a uterine niche. So that is what it is. Sorry. So question number 4, we have got our uterus there. You can see it's bulky here, and then you can see here on the endometrial cavity there's some free fluid, and there is an adhesion that you see here. You can see there is an adhesion there pointed by the arrow. So what is this? Foreign body? No, definitely this is not a foreign body. Uterine synechia, yes. So what happens is, when there's inflammation of the uterus or there's endometritis, there is going to be formation of inflammatory exudate. Then you can see the fluid there, and then these adhesions can form due to inflammation of the uterus. So these ones are what are called the Asherman syndrome or uterine synechia. So the adhesions which occurs as a sequel to endometritis or chronic inflammation of the endometrial cavity is what we call the uterine synechia. RPOCs, which are retained products of conception, no, this is not retained products. So the normal uterus, that's definitely not a normal uterus. This is an abnormal uterus. Question number 5. So we have put the uterus there, then there's endometrial fluid there, and there's an echogenic lesion that you're seeing here. That's an echogenic lesion. So what is this? Endocavity fibroid, uterine polyp, endometrial cancer, or hematometria. So a lesion that is hyperechoic, that is uniformly hyperechoic like that in the endometrial cavity, is a sonographic feature of a uterine polyp. So this is a polypoid mass. So that's a polyp. Though there can be overlaps also with an endometrial cavity fibroid. So, but a fibroid normally is not as echogenic like that, like what you're seeing here. So this is a small echogenic lesion there. So it mostly favors a uterine polyp. So there's no sonographic sign of an ovarian cancer. There is no blood collection there in the uterine cavity there. So this is a polyp. Question number 6. So you can see the reticular pattern that we have there in the ovary. That's the reticular pattern there that we have. So what is that? That's a hemorrhagic cyst. Yes. So blood can form this fishnet appearance like that. It also can clot, and then the clot can also retract. So this is a sonographic feature or sign of a hemorrhagic ovarian cyst. So simple ovarian cyst, this is not a simple ovarian cyst because there is a hemorrhagic contents inside. Ectopic pregnancy, definitely there is no sonographic sign of a fetus or any form of pregnancy or gestational sac that we are seeing there. So it's not an ectopic pregnancy. Endometrioma, that's not a chocolate cyst because we are not seeing the typical ground glass appearance of a normal endometrioma or a chocolate cyst. So this is a hemorrhagic cyst. Question number 7. You can see here the configuration that we have here with a uterus there. We have got another uterus that we have here. Those two uteruses, and then they are converging somewhere there on the cervix there. So these two are what is called uterine diadeps or a double uterus. Uterus there, uterus there. So this is uterine diadeps. Biconnate uterus? No, this is not a biconnate uterus because there are two distinctive types of uterine uteruses. So I've discussed on the other presentation where I was talking about the anomalies of the uterus, congenital anomalies of the uterus. So go through that so you can see the distinction between these congenital malformations of the uterus. So it's not a septated uterus. Again, there's no septum that is dividing the two. They are actually very distinctive uteruses. So it's not a normal uterus again. Question number 8. So you can see the uterus there. You can see this is the endometrium. The endometrium there, which is thick, and then you can see there are cystic spaces inside. So what is that? So this is what's called endometrial hyperplasia. So, but when you see endometrial hyperplasia of this nature, you must also give endometrial cancer as a differential. So they need to do further investigations to exclude endometrial cancer. So this is a thickened endometrium which is in keeping or consistent with endometrial hyperplasia. Endometrial polyp, so that's not a polypoid mass. So you can see it was affecting the whole endometrium. So missed abortion, no, this is not a missed abortion. We are not seeing any fetal pulse or any sign of significance or relevance of anything that we can call a missed abortion. So there's nothing to show. Normal uterus, so this can be a normal uterus. The other closer differential to this, though this is too small, the other closer differential will be a molar pregnancy. So a molar mass can appear like that, but it will be bigger. At the same time, a molar mass has to correlate with a pregnancy test. So without that, so this is an endometrial hyperplasia. So question number 9. So you can see here, you can see the uterus there, and there is a degeneration that is taking place. Then there is an irregularity in the endometrium there, and you can see the rest of the uterus appears to be very hyperechoic uterus, ill-defined, and when color Doppler, you can see that there's a neovascularization or there's hyperemia within the mass and substance of the uterus. So when you see this configuration happening, so that is consistent with an endometrial cancer. So this is a cancer that you are seeing there that is going on here. So this is not endometritis because you can see that there is an irregularity of the mass of the endometrium, and also the uterus is getting hypoechoic, meaning to say that there is a process that is invading and destroying the tissues of the endometrium. Polyps, there are no polyps there. The fibroid, is no sonographic sign of a fibroid. So this is endometrial cancer that is causing that cystic degeneration as well. So question number 10. So here, what do we have here? PCOS, no, there's no sign of polycystic ovarian syndrome because the follicles, there are not as many on the peripheries. These ones are just very few. At the same time, massive ovarian edema, there's no sonographic sign of a massive ovarian edema. Thecal uterine cysts, there are no sonographic sign of thecal uterine cysts. To me, this is a dominant follicle. This is a dominant follicle, which is very normal pathology in every menstrual cycle. So one of the follicles, it grows big, is the one that will rupture or burst to release an egg or ovum for fertilization. So this is a normal configuration. That's a very normal ovary. So ladies and gentlemen, this marks the end of this quiz session. So we'll meet again tomorrow where we have got another session of a quiz session. Take this one seriously because they refresh you and you can see as many bank of pathologies as much as you can. So ultrasound is a game of repetition. The more you see different pathologies, the more you become a better practitioner. So the unfortunate part of the thing is you might not see certain conditions where you practice. So the good thing is if we do these sessions together, you can always refresh and always keep up to date with the pathologies that you might not see in your respective departments. Thank you so much. Don't forget to share our educational content and also subscribe so that you don't miss any other lecture series. So for the sake of continuity, we record all our videos and then you can always visit them another time you are free. Thank you so much. Hello everyone, welcome. So in this presentation, I am going to talk about Down syndrome screening on ultrasound in the first trimester. So the key ultrasound signs you must know are the ones that I am going to briefly discuss. So in this presentation, I am particularly going to talk about the two most common. So first trimester ultrasound markers for Down syndrome, which is also called the trisomy 21. The first trimester screening is typically performed between 11 weeks, 0 days, and 13 weeks, 6 days, when the crown rump length is 45 to 84 millimeters. Ultrasound markers help identifying fetuses at increased risk of Down syndrome and are often combined with maternal age and biochemical markers. So increased knockout translucency, which is called the NT, which is the most important marker in the screening for trisomy 21 on ultrasound in the first trimester. Definition: increased fluid accumulation beneath the fetal neck skin. Timing: 11 to 13 plus 6 weeks when the crown rump length is between 45 to 84 millimeters. So the measurement: obtain a true mid-sagittal view. Fetus in neutral position. Measure the maximum thickness of the translucent space. Abnormal NT above the 950th percentile for crown rump length. Generally, an NT that is above 3 millimeter is considered significantly increased. So the significance: strongest first trimester sonographic marker for Down syndrome, also associated with congenital heart defects, Turner syndrome, other chromosomal aberrations, and genetic syndromes. So also, absent or hypoplastic nasal bone is another sonographic marker of Down syndrome. Evaluate in the mid-sagittal facial profile. Normally, the nasal bone appears as a bright echogenic line. Absent or short nasal bone increase the risk of Down syndrome, more common in affected fetus than normal fetuses. So here we've got a case report. Then you can see the differences in terms of the normal and abnormal NT. So here is the knockout translucency. So you can see the fluid at the back of the neck. This one, which is anechoic. So you can see this is the NT measurement there. So you can see it's very much increased. It's very much increased, and is more than 3 millimeters in thickness. This is the nasal bone here, but if you check here closely, you can see with the skin crease there is no nasal bone. The nasal bone should be below the skin crease there. They should appear like an equal sign, so it's not there. If you look at the normal one here, you can see the skin crease there and then the equal sign which is here, and you can see that this is a normal nasal bone. There's an absent nasal bone here, and the knockout translucence, compare the difference there between this one and that one. This one is very much thickened, and this one is very normal. Do not confuse the space between the fetal skin there and there and the uterine wall here, or the amniotic layer there. Do not confuse this one. This is not the NT. The NT is this one. That's our NT. So this is an abnormal knockout translucency. So this is what you'll be looking at when you're screening for Down syndrome. Make an effort to get this profile view and then measure the NT and also check on the nasal bone. So this is how you write a typical sonographic report. First trimester obstetric ultrasound report. The patient name, the date of birth of the patient, the hospital ID, the date, the referring clinician's name. Examination, first trimester obstetric ultrasound, 11 to 13 plus 6 weeks, knockout translucent assessment. Then the clinical indication, routine first trimester aneuploid screening. The technique, transabdominal ultrasound examination performed with grayscale imaging, fetal biometric measurements, and first trimester screen markers were assessed. So the findings, so you have to document the findings in every type of a sonar that you do or an ultrasound that you do. So a single life intrauterine pregnancy is demonstrated. Fetal cardiac activity is present, measuring 156 beats per minute. Crown rump length CRL 79.0 mm, corresponding to a gestational age of 12 weeks and 7 days. Knockout translucence NT, which is 37 millimeters, abnormally increased for gestational age. Nasal bone is not visualized, absent nasal bone. Fetal profile was obtained in the true mid-sagittal plane. No obvious gross structural abnormalities are identified on this limited first trimester examination. Amniotic fluid appears adequate. Placental location anterior, maternal, uterine, and adnexia, they appear unremarkable. So the impression on this ultrasound scan, single life intrauterine pregnancy with the CRL corresponding to 12 weeks, 6 days. Abnormally increased knockout translucency, NT measuring 37 millimeters, and the absent fetal nasal bone. These findings are high risk first trimester markers for fetal chromosomal aberrations, particularly trisomy 21, Down syndrome, trisomy 18, and trisomy 13, which is the Turner syndrome 45X. So an increased NT also carries an increased risk of major congenital heart defects, certain genetic syndromes, e.g. Noan syndrome, fetal heart drops, and adverse pregnancy outcomes. So this is just the detailed notes. I'm just giving you this information so that you have an imprint of what we are talking about, or the risk of an increased NT on ultrasound. So yeah, so the basic thing or the major thing that you're supposed to do is to report on the abnormal NT and also comment the nasal bone. Also, you have to talk about the ductus venosus if you have examined it, or if we are lucky to see it nicely. So the recommendations, these are basically for the referring clinicians. It's not really for the person who does the sonar. Urgent referral to a fetal medicine specialist for comprehensive assessment is recommended. Offer genetic counseling. Recommend cell-free fetal DNA, NIPT, if appropriate. Discuss diagnostic testing, chorionic villus sampling, or amniocentesis for definitive fetal karyotyping. Detailed first trimester anatomical assessment and second trimester anomaly scan 18 to 22 weeks. Fetal echocardiography at approximately 20 to 24 weeks is also recommended, particularly if the increased NT persists or genetic testing is abnormal. So, ladies and gentlemen, the first trimester scan is very, very critical for dating the pregnancy and also for aneuploid screening. We also do the pre-eclampsia screening in the first trimester. So this examination is very, very critical. So be very careful to get a profile view so that you can assess the NT and also the nasal bone if it's absent or is present. Okay, you must also not ignore the ductus venosus. I'm going to show you how we do the ductus venosus in detail. When we do this in detail, I'm going to give you the notes on how to do a first trimester ultrasound examination. Thank you so much. I hope you're enjoying learning. I also wish you to share this educational content with your colleagues and friends. Ladies and gentlemen, don't forget to like, share, and comment on our YouTube channel. We need you to be interactive so that we engage and also we can see areas of improvement or the areas you feel that we must tackle next. Thank you so much. Hello, ladies and gentlemen, and welcome. So here is an explanation and answers to our scenario-based quiz questions on pelvic pathology. So the first question was, a 35-year-old woman presents with pelvic pain. Transvaginal ultrasound shows a well-circumscribed hypoechoic solid mass arising from the myometrium with posterior acoustic shadowing. What is the most likely diagnosis? A. Endometrioma. B. Uterine fibroid leiomyoma. C. Ovarian torsion. D. Tubo-ovarian abscess. So the answer is B. Uterine fibroid leiomyoma. Fibroids typically appear as hypoechoic, well-defined solid masses with variable shadowing due to their fibrous content. Location, they can be submucosal, intramural, or subserosal. They are variable. So question number 2, a reproductive age woman has a unilocular ovarian cyst with homogeneous low-level internal echoes, giving a ground glass appearance, no internal vascularis flow, and possible hyperechoic wall foci. What is the diagnosis? A. Simple function of cyst. B. Hemorrhagic cyst. C. Endometrioma, which is the chocolate cyst. D. Mature teratoma, which is the dermoid. So our answer is C. Endometrioma, which is the classic ultrasound feature, is the ground glass echogenicity from old blood. Often chronic, may be multilocular or bilateral. Question number 3. A postmenopausal woman has an endometrial thickness of 12 millimeters with a focal echogenic mass protruding into the cavity and a single feeding vessel on color Doppler. What is the likely finding? A. Endometrial atrophy. B. Endometrial polyp. C. Adenomyosis. D. Ovarian cyst. So our answer is B, which is an endometrial polyp. Polyps often appear as focal echogenic intracavital masses with a single vessel, pedicle artery sign, thickened endometrium in postmenopausal women's further evaluation. Question number 4. Young woman with acute pelvic pain and positive beta HCG has an empty uterus and a complex adnexal mass with a tubal ring sign and moderate free fluid. What is the diagnosis? A. Ruptured hemorrhagic corpus luteum. B. Tubal ectopic. C. Dermoid cyst. D. Fibroid degeneration. So our answer is B. Tubal ectopic pregnancy, key findings: empty uterus plus adnexal mass plus positive pregnancy test, sliding sign in the ring of fire, vascularity may be seen. Question number 5. Ultrasound shows an enlarged uterus with heterogeneous myometrium, ill-defined hypoechoic areas, small myometrial cyst, and poor definition of the endometrial myometrial junction. What is the pathology? A. Multiple fibroids. B. Adenomyosis. C. Endometrial carcinoma. D. Hydrosalpinx. So our answer is B, which is adenomyosis, diffuse or focal junctional zone thickening, and myometrial heterogeneity and cysts are characteristic. Question number 6. A complex adnexal mass with thick walls, internal septations, debris, and surrounding hyperemia is seen in a patient with fever and pelvic pain. What is a common diagnosis? A. Endometrioma. B. Tubo-ovarian abscess from PID. C. Simple ovarian cyst. D. Subserosal fibroid. So answer is B. Tubo-ovarian abscess. Inflammatory masses show complex cystic solid appearance, debris, and increased vascularity, often associated with the pyosalpinx. Question number 7. A large ovarian mass contains echogenic fat calcifications with shadowing and hair-like structures, which is the dermoid plaque. What is it? A. Endometrioma. B. Hemorrhagic cyst. C. Mature cystic teratoma, which is the dermoid. D. Mucinous cystadenoma. So our answer is C. Mature cystic teratoma dermoid, classic tip of the iceberg sign or dermoid mesh from fat, hair, or calcifications. Question number 8. Enlarged ovaries greater than 10 cubic centimeters with plus or minus 12 peripheral follicles, 2 to 9 millimeters in strings of pills appearance in a patient's irregular menses. What is the diagnosis? A. Normal ovaries. B. Polycystic ovarian morphology, PCOM, associated with PCOS. C. Bilateral endometriomas. So D. Ovarian torsion. So in this scenario, our answer is B, which is the polycystic ovarian morphology, which supports PCOS diagnosis when combined with clinical and biochemical features. So question number 9. A patient with sudden severe unilateral pelvic pain has an enlarged ovary with the peripheral follicles, abs and decreased Doppler flow, and a wipe sign of the pedicel. What is it? A. Hemorrhagic cyst. B. Ovarian torsion. C. Ectopic pregnancy. D. A fibroid. So answer is B. Ovarian torsion, which presents an enlarged ovary with a stromal edema, a twisted vascular pedicel, are key. Flow may be present or absent. Question number 10, which is our last one. A tubular fluid-filled structure separate from the ovary with waste or incomplete septations, Kogu sign in the low-level echoes. Common association: A. Endometrial polyp. B. Hydrosalpinx, often from prior PID. C. Submucosal fibroid. D. Simple para-ovarian cyst. So our answer is B, which is the hydrosalpinx. Dilated fallopian tube appears sausage-shaped or folded. So, ladies and gentlemen, this brings us to the end of our presentation on the quiz answers and their explanations, so you can understand that as a sonographer, you need to understand or to have an appreciation of the different pathologies, how they look like, without even seeing the image. You must have that in the back of your mind. At the same time, you must also appreciate the role of patient history whenever you are doing an examination. Like for you to confirm that somebody has an ectopic pregnancy, especially if it's too small or non-viable, you must have an understanding of the pregnancy test result. Thank you so much. Don't forget to subscribe to our channel, like and share. If you've got any areas that you feel that we ought to improve, please just click the type button and send us a message on the comment section. Thank you so much. Hello everyone, and how are you? So let's discuss the quiz video questions that I gave you yesterday, in which I said, can you diagnose this pelvic mass? 99% get it wrong. So I want you to listen very carefully as we dissect each question. Don't miss any part of this, because it's going to help you improve your vocabulary of pelvic pathologies. So this is our first question here. You can see there's some free fluid there, which are elongated. This is anechoic free fluid there, and this is uterus there. So you can see the free fluid again there, and then the uterus there. That's your ovary there, the ovary appear normal. There is also a pocket of free fluid there, which is also elongated. So this is in keeping with hydrosalpinx. So this is bilateral hydrosalpinx. So if you were thinking about hydrosalpinx, you are very much 100% correct. So what is hydrosalpinx? Hydrosalpinx is fluid collection in the fallopian tubes. So when fluid collects in different areas in the body, it has got different names. If the water collects in the head, it's called hydrocephalus. If it collects in the lungs, in the pleural space, it's called a pleural effusion. If it collects around the heart, is what we call the pericardial effusion. If the fluid is in the abdomen, the peritoneum, we call that ascites. If fluid is collecting in the kidneys, is hydronephrosis. Then if this fluid now is collecting in the fallopian tubes, we call it hydrosalpinx. Mostly hydrosalpinx develop as a sequel to an inflammatory process, or this inflammation of the fallopian tubes. That's where we see it as inflammatory exudate. So question number 2, you can see we have an ovary here there, and you can see here there are multiple septated cysts there, and you can't see or the stroma of the ovary. It's very difficult for you to differentiate the stroma from the rest of the ovary. So this is the morphology of a theca lutein cyst. So that's the morphology of theca lutein cyst. So these theca lutein cysts, they normally exist due to a surge in beta HCG that mostly happen with molar pregnancies. So those patients with molar pregnancies are the ones which mostly develop these theca lutein cysts. Question number 3. So there you see we've got a huge mass there, and then you can see there's some more blood flow on power Doppler there, and you can see there's some solid components there, but they are sedimenting by gravity, because you can differentiate the mass from the fluid on ultrasound. So that demarcation tells us that there is some debris which are inside. It's not entirely a solid mass, so there's free fluid and some debris which are inside, and there are also pockets where we do have blood that is flowing on our Doppler. So, ladies and gentlemen, this is in keeping with a malignant transformation. So, this is a mucinous cystadenoma. So, a mucinous cystadenoma is a benign lesion. So, there are no cancerous transformations. But here now, because we are seeing intralesional perfusion, so that is the configuration or the morphology of a malignant transformation. So it is in keeping with mucinous cystadenoma. So now let's go to question number 4. So you see here, there's this lesion there that you are seeing there. You can see here, you can see this is very echogenic, and then there's a cystic portion, and you see there's posterior acoustic enhancement there. So this lesion, then, ladies and gentlemen, is in keeping with dermoid cyst. So this is a rocking tax nodule, and you can see the tip of the iceberg sign there, acoustic shadow, distal acoustic shadow in there. And then this is the rocking tax nodule. So we say that a dermoid cyst can have any components, be it the teeth, be it hair, fat. So it can have anything. So this is a dermoid cyst. It's a rocking tax nodule. Question number 5. So you see here we've got our uterus there. You can see there's a lesion there that is very hyperechoic. That is very hyperechoic there. It's in fact echogenic. So the rest of the uterus relative to this, you can see is hypoechoic. This is hyperechoic or echogenic. So this echogenic mass, ladies and gentlemen, is in keeping with a lipoleiomyoma. It's a lipoleiomyoma. So it's a fibroid that is deriving from fat. So it's called a lipoleiomyoma. Is the one that is echogenic, or that has got the configuration that looks like this. So this is a lipoleiomyoma. So let's now come to question number 6. So you can see here in the cervix is a mass that has got hypervascularity. So a hypervascular mass like this, this is a transformation of neovascularization. So when there's a cancer, the cancerous mass, it tends to have more blood supplying it, or it needs a lot of blood supply. So many new vascular channels, they open. So you can see that there's a lot of blood that is going to that. So this is the morphology of neovascularization, which is a cancerous transformation. So this is a malignant lesion. So the one that you're seeing, that's a malignant lesion there. So this is a cancer of the ovary. That's ovarian cancer. That's ovarian cancer. Okay. Now let's do question number 7. So you can see here with the uterus, and in the center of the uterus, you can see there's some free fluid which are inside. This is another pocket of collection of free fluid again in the uterus. So if there's just anechoic free fluid like that, that one that you're seeing there, it is what we now called hydrometria. So water inside the endometrial cavity is called hydrometria. It's hydrometria. So we have got hydrometria there. So if there's also an inflammatory process like endometriosis that is happening within the uterus, it causes a collection of free fluid in the endometrial cavity that we call hydrometria. So this is hydrometria. Now we do have good question number 9. So you can see the uterus there, and you can see here there's an echogenic lesion there. There's an echogenic lesion there that is very much elongated. So you can see this is an IUCD. So this is an intrauterine contraceptive device, and be Mirena. That one is in keeping with a displaced. It was supposed to be there in the endometrial cavity up there, but you can see it's in the endocavity. It's in the endometrial cavity. So this is a displaced IUCD located entirely in the cervix. So that's an IUCD that's misplaced or displaced. So, ladies and gentlemen, now let's discuss our last question, which is question number 10. So, what we have here is the uterus, and you can see there is the grapevine appearance in bilateral ovaries this here, and there's some free fluid around the ovary like that, like that. So, this is morphology, ladies and gentlemen, is in keeping with ovarian torsion. So, this is ovarian torsion that is masquerading as a molar pregnancy. It looks like a molar mass, sorry, it looks like a molar mass. So that is cystic degeneration of the ovaries due to, or secondary to, or is a sequel to um, ovarian torsion. That's degeneration that happens when there's a torsion. So, ladies and gentlemen, this brings us to the end of our video clip, short video clip based quiz. This is very, very critical because if you analyze these images like that, you enhance your skill of diagnosis. So don't take this lightly. This is the foundation, this is the fulcrum, this is the pith of medical ultrasound practice. Thank you so much, ladies and gentlemen. Don't forget to subscribe to this channel, and we keep learning. Share with your colleagues as well. Comment and like our videos. Thank you so much. How are you, ladies and gentlemen? So now we continue with pelvic anatomy. So in this presentation, I'm going to discuss about the ovarian anatomy. So detailed notes on the anatomy of the ovaries and the fallopian tubes. So we would touch on the fallopian tubes in the next lecture because it will be too long. So ovarian anatomy. The ovaries are paired female reproductive organs responsible for production of ova, oogenesis, secretion of female sex hormones, estrogen, progesterone, inhibin, and relaxin. They are the female gonads and are located within the pelvic cavity on either side of the uterus. So these are the ovaries there, the ovaries there, the uterus is here, the fallopian tube is there, the cervix there, and the vagina there. So anatomically, that's where you have your two ovaries like that. So the gross anatomy of the ovary. Location, the ovaries lie in the ovarian fossa on the lateral pelvic wall. So this is the lateral pelvic wall there. Posterior to the broader ligament, inferior to the external iliac vessels, anterior to the ureter and internal iliac vessels. The ovarian fossa is bounded by superiorly external iliac vessels, posteriorly ureter and internal iliac artery, anteriorly obliterated uterine artery. So the size of the ovary in a reproductive age woman, each ovary measures approximately length 3 to 5 centimeters, the width 1.5 to 3 centimeters, the thickness 1 to 2 centimeters. So the weight of an ovary is between 5 to 8 grams. Size varies according to age, the menstrual cycle, pregnancy, and menopause. So the shape of an ovary, the ovary is almond shaped. So you see that's an almond shaped, slightly flattened, white to grayish white. That's the color. The surface of the ovary has two surfaces. Medial surface face the uterus and contains loops of bowel. The lateral side lies against the ovarian fossa containing the pelvic wall. So the borders of an ovary, anterior mesovarian border. So attached to the broader ligament by the mesovarium contains the ovarian hilum. So you see here is your mesovarium here. We got our broader ligament which is here. The suspensory ligament that is there. So this is the ovary, the right ovary and the left ovary there. So this is the anatomical position of the ovary there. So this is the ovarian ligament there and the uterine fallopian tubes which are here. We got the suspensory ligament again here, which is holding the ovaries in space. So posterior border, free border, no peritoneal attachment. So there's no peritoneal attachment at the posterior border of the ovary. So the pores of the ovary, tubal, the superior pore, so which is the upper pore that we have here, and then we have got the lower pore, that is the upper pore there, and the lower pore. Connected to the fimbria by the ovarian ligament of the ovary, so you can see that's where it is connected to the fimbria there. And then the uterine inferior pore connected to the uterus by the ovarian ligament. So it's connected to the uterus there by the ovarian ligament. That's the ovarian ligament there. So that's the lower pore. This is the uterus there. So the attachments of the ovary, we've got the mesovarium, a short peritoneal fold attaching the ovary to the broader ligament. So we've got the mesovarium there that we have there. That's the mesovarium that we have there. That's the mesovarium. Functions of the mesovarium supports the ovary, carries the blood vessels, carries nerves, and carries the lymphatics. So the ovarian ligament, so this is the ovarian ligament, the uterine ovarian ligament there, you see there it's attaching the ovary to the uterus. It's a fibromuscular band connecting the ovary, the uterus, runs from uterine cone to the inferior pore of the ovary. So that's where it runs from the inferior cone of the uterus there into the lower pore of the ovary. This is the upper pore of the ovary, the lower pore of the ovary. So you've got the uterus ovarian ligament there that is holding the ovary in place. So the suspensory ligament of the ovary, which is called the infundibulopelvic ligament. So this is the suspensory ligament of the ovary. You can see it there. So peritoneal fold connecting ovary to the lateral pelvic wall contains ovarian artery, ovarian vein, lymphatics, nerves, very important surgically. So it is very important surgically, this suspensory ligament. So we got the fallopian tube there, the uterus there, utero-ovarian ligament, the ovary there. We got the broader ligament also this side. But this one that is upper there, that's the suspensory ligament. So the internal structure of the ovary. Internal structure, the ovary consists of the surface epithelium. So we have got the surface epithelium, which is the surface layer of the ovary. Or simple cuboidal epithelium. These are the type of the cells which makes up the surface epithelium of the ovary. Previously called the germinal epithelium. So they say it used to be called the germinal epithelium. This name is incorrect because it does not produce germ cells. So that's why it was then changed to just surface epithelium. Okay, we also got the tunica albuginea. The tunica, this is the tunica albuginea that we have there. That's the tunica albuginea. So dense connective tissue beneath the epithelium provides structural support. So the tunica albuginea confers the structural support to the ovary itself. So also with the cortex, which is the functional part of the ovary. So this area that we have here, this is our cortex. That's the cortex, the whole of that. That's the cortex. The outer functional region contains the ovarian follicles. So you can see these are the ovarian follicles that we have there. Then the corpus luteum. So you can see the corpus luteum there. It contains also the corpus albicans, which is the degenerated corpus luteum. We are going to talk about that when we talk about the ovarian cycle. And then the stromal tissue, it also contains the stromal tissue. So the follicles include, these are the follicles, the different follicles. So you can see here we have got the primordial follicle, the primary follicle, the primordial follicle, the secondary follicle, then the early tertiary follicle, the atretic follicle there, then the pre-ovulatory late tertiary graphene follicle. Then you've got the corpus luteum, corpus albicans. We are going to discuss about the ovarian cycle. So the follicles include the primordial follicles, the primary follicles, the secondary follicles, the graphene follicles. Ovulation occurs here. Okay, that's where ovulation occurs when the graphene or the mature follicle ruptures, and then it will transform into a corpus luteum cyst when the ovum is shed. So also with the medulla, which is this central part of the ovary here, we can see there's blood supply, the nerves and all that. So the inner vascular region contains the blood vessels, the lymphatics, the nerves, loose connective tissue. No follicles are present. You can see that there are no follicles which are present in the medulla of the ovary. So the blood supply of the ovary, the arterial supply, ovarian artery, origin, abdominal aorta just below the renal arteries, travels through suspensory ligament, anastomosis with uterine artery. So you can see the uterine artery branch provides the collateral ovarian circulation. So this is the anatomy, the iliac artery there, the uterine artery, then you have with the ovarian ligament there, then you have with the infundibulopelvic ligament there, and then the fallopian tube, the external iliac artery there. This is the right ovarian artery. See, that's the right ovary, which is a direct branch of the aorta. So it directly branch from the aorta, then it comes like that. So this is the blood supply of the ovary. So the venous drainage of the ovary forms the palmariform plexus, right ovarian vein from the inferior drains into the inferior vena cava. Then the left ovarian vein drains into the left renal vein. So you can see they drain differently. We are saying that the right ovarian vein drains in the inferior vena cava, whereas the left ovarian vein now drains in the left renal vein. So you can see here what we have. So this is the right renal vein there. Then we got the right ovarian vein there, which is directly draining into the inferior vena cava. And then we do have got our left ovarian vein there, which is draining directly into the left renal vein. So that's the difference, the anatomical difference is the left ovarian drains into the left renal vein, which will eventually drain into the inferior vena cava, whereas the right ovarian vein drains directly into the inferior vena cava. So the nerve supply of the ovary from ovarian plexus, renal plexus, aortic plexus, and the sympathetic fibers T10 to T11. So this is the nerve supply of the ovaries. So we are saying they are coming from the ovarian plexus, renal plexus, aortic plexus, sympathetic fibers T10 to T11. Pain from the ovary is often referred to the periumbilical region because of the lineage of the nerve supply. So that's the referred pain. So the lymphatic drainage of the ovary drains to the para-aortic lumbar lymph nodes. This differs from the uterus, which drains primarily to the pelvic lymph nodes. So the function of the ovary performs two major functions, which is the exocrine function, which produces mature ova. Then you also have got the endocrine function, which produces estrogen, progesterone, inhibin, relaxin, anti-Mullerian hormone AMH. So, ladies and gentlemen, this brings us to the end of our presentation on ovarian anatomy. So, it is this ovarian anatomy that formulates the foundation that we use to build on the sonographic appearances and the pathologies that you find in an ovary. If you understand the anatomy building up on the sonographic appearances, the pathologies will be much easier for you. So I've given the skeleton. Thank you so much. Hello, ladies and gentlemen. Welcome, and how are you? My name is Last. So learning medical ultrasound has never been this easy. So in this presentation, we are going to do ultrasound ovarian pathology quiz. So I urge you to attempt all the questions. Please, in the comment section, type the provisional answers that you feel they are correct. So if it's number 1, then if it's B, you say B, or you can put the pathology. Then after, we'll discuss the results. Please, these quiz questions, they help you to master the different pathologies. Take them seriously. I urge you to take them seriously. As you know that ultrasound is a pattern recognition profession. You have to recognize how different pathologies present sonographically. So it's a pattern recognition. So for your brain to understand these different pathologies, you need to see them time and again in their various manifestations. That's why we are trying to build up with this quiz so that you can see the pathologies over and over again. Okay, so let's start. Question number 1. A 28-year-old woman presents with pelvic pain. Transvaginal ultrasound shows a 4 cm ovarian cyst with a fine internal echoes and a fishnet or reticular pattern. No solid components or Doppler flow within the echoes. What is the most likely diagnosis? So you can see this is the sonographic finding. That's the finding there. So what is this? A. Serous cystadenoma. B. Hemorrhagic corpus luteum cyst. C. Mature teratoma dermoid. D. Endometrioma. So what is it? Look at the keywords. 4 cm cyst with fine internal echoes and a fishnet or reticular pattern. Fishnet reticular pattern. So what's the choice? Serous cystadenoma, hemorrhagic corpus luteum cyst, mature teratoma, endometrioma. Okay, let's go to the next question. Question number 2. Which ultrasound feature is most characteristic of an endometrioma, a chocolate cyst? So this is an endometrioma, which is a chocolate cyst. So how do we describe this sonographically? This will help you in your report writing. Posterior acoustic enhancement with thin walls, homogeneous low-level internal echoes, ground glass appearance, fat fluid levels with bright echoes, multilocular mass with the papillary projections. So how do we best describe an endometrioma on ultrasound? A. Posterior acoustic enhancement with thin walls. B. Homogeneous low-level internal echoes, ground glass appearance. C. Fat fluid levels with bright echoes. D. Multilocular mass with the papillary projections. Question number 3. A dermoid plaque rocking task nodule is a characteristic feature in which ovarian lesion. So this is the dermoid. That's the dermoid there. That's the dermoid there. So the rocking task nodule there, you have it here. We have it here. So the dermoid plaque. That's the dermoid plaque that we're having here. So A. Hemorrhagic cyst. B. Mature cystic teratoma dermoid. C. Mucinous cystadenoma. D. Thicker cyst. So the question again, a dermoid plaque, the rocking task nodule, is a classic finding in which ovarian lesion. A. Hemorrhagic cyst. B. Mature cystic teratoma dermoid. C. Mucinous cystadenoma. D. Thicker cyst. Question number 4. A postmenopausal woman is a 6 cm unilocular thin-walled ovarian cyst with no internal echoes or solid components. What is the most appropriate next step according to common guidelines? A postmenopausal woman has a 6 cm unilocular thin-walled ovarian cyst with no internal echoes or solid components. What is the most appropriate next step according to common guidelines? A. Immediate surgical removal. B. Follow up around ultrasound in 6 to 12 months. C. No follow up is needed if less than 5 centimeters. D. Color Doppler to assess for neovascularity. So which is the most likely response?
A postmenopausal woman has a 6 cm unilocular thin-walled ovarian cyst with no internal echoes or solid components. What is the most appropriate next step according to common guidelines? Immediate surgical removal, follow-up ultrasound in 6 to 12 months, no follow-up needed if less than 5 centimeters, color Doppler to assess for neovascularity. So question number 5, which finding is most suggestive of an ovarian torsion on ultrasound? So that is ovarian torsion on ultrasound. That's ovarian torsion. You can see, compare this ovary with this other one. So this is the right ovary, the left ovary. This ovarian torsion is here. Enlarged ovary with the peripheral follicles and absent color flow on Doppler. B. Ground glass appearance with low level echoes. C. String of pearls sign. D. Thick septations with color flow. Which finding is most suggestive of an ovarian torsion on ultrasound? Enlarged ovary with the peripheral follicles and absent Doppler flow. Ground glass appearance with low level echoes. String of pearls sign. Thick septations with color flow. Question number 6. A patient with infertility shows bilateral enlarged ovaries above 10 cubic centimeters with greater than 20 small follicles 2 to 9 millimeters arranged peripherally. What diagnosis fits best? So this is the finding. So these are the multiple follicles that we have there. A. Bilateral dermoids. B. Polycystic ovarian morphology. C. Bilateral endometriomas. D. Ovarian hyperstimulation syndrome. A patient with infertility shows bilateral enlarged ovaries above 10 cubic centimeter with greater than 20 small follicles, 2 to 9 millimeters arranged peripherally. What diagnosis fits best? Bilateral dermoids A, polycystic ovarian morphology B, C, bilateral endometriomas, D, ovarian hyperstimulation syndrome. Question number 7. A complex cystic mass with multiple thin septations, no solid nodules, and a low level echoes is seen. What is the most likely benign diagnosis? That's the mass, the ovarian lesion that we have here. What is the most likely diagnosis? A. Serous cystadenoma. B. Mucinous cystadenoma. C. Mature teratoma. D. Borderline tumor. So again, a complex cystic mass with multiple thin septations, no solid nodules, and a low level echo is seen. What is the most likely benign diagnosis? Serous cystadenoma, mucinous cystadenoma, mature teratoma, and borderline tumor. Question number 8. Which feature raises highest concern for malignancy in an ovarian mass on ultrasound? So you can see this is the characteristic malignant tumor on ultrasound. This is the Doppler finding. A. Solid papillary projections with vascular flow. B. Homogeneous low-level echoes. C. Posterior acoustic shadowing from calcifications. D. Unilocular simple cyst less than 5 centimeters. So again, question 8. Which feature raises the highest concern for malignancy in an ovarian mass on ultrasound? A. Solid papillary projections with vascular flow. B. Homogeneous low-level echoes. C. Posterior acoustic shadows from calcifications. D. Unilocular simple cyst less than 5 centimeters. So what is the correct choice? Question number 9. A pregnant patient on fertility drugs develops bilateral enlarged ovaries with multiple large cysts. What is this condition? So you can see this is the ovarian morphology that we are now having. A. Endometriomas. B. Thecal uterine cyst hyperreatio luteinalis. C. Bilateral hemorrhagic cyst. D. Krankenberg tumors. So which is the best choice? A pregnant patient on fertility drugs develops bilateral enlarged ovaries with a multiple large cysts. What is this condition called? So this one, so this is patient is on fertility drugs. A. Endometriomas. B. Thicker lutein cyst, hyperreaction lutinalis. C. Bilateral hemorrhagic cyst. D. Krankenberg tumors. Question number 10. A 35-year-old woman has a para-ovarian cyst. On ultrasound, where is it typically located relative to the ovary? So here is the ovary with the para-ovarian cyst. A. Within the ovarian stroma. B. Separate from the ovary, often in the broad ligament. C. Posterior to the uterus. D. Adherent to the fallopian tube fimbria. So, which is the best location for a para-ovarian cyst? A 35-year-old woman is a para-ovarian cyst on ultrasound. Where is it typically located related to the ovary? A. Within the ovarian stroma. B. Separate from the ovary, often in the broad ligament. C. Posterior to the uterus. D. Adherent to the fallopian tube. Thank you, ladies and gentlemen. This brings us to the end of our ovarian pathology quiz session. I hope you are enjoying these quiz sessions. They help boost your pathology vocabulary. So what I need you to do is I need you under the comment section to jot down the provisional diagnosis that you think or the correct response that you think. Like you say question number 10, then you can say the answer is A. The question B, question 9, answer is A, just like that. So that will keep the conversation. I also become happy that you guys are following and you are also learning. So the core of this quiz is for us to learn as much as possible. Please don't forget to subscribe and also press the notification button so that you can receive more quiz sessions as they come, so that we keep on learning. Learning keeps us fresh. We freshen up every time. That's the basic rule to mastering medical ultrasound. Thank you so much.
The ultrasound sign everyone misses. Can you spot it? So this is a case introduction. A 27-year-old woman presents with lower abdominal pain for 2 days, vaginal mild bleeding, positive pregnancy test at 6 weeks, hemodynamically stable. The emergency physician requests a pelvic ultrasound. A 27-year-old presents with lower abdominal pain for 2 days, mild vaginal bleeding, positive pregnancy test at 6 weeks, hemodynamically stable. The emergency physician requests a pelvic ultrasound. Here are the image findings. So this is the uterus. So you can see here, that's the endometrium there. There is a bit of some free fluid there in the pouch of Douglas. Empty uterus, endometrial thickness of 10 millimeter. No obvious intrauterine gestation is noted. So image number 2. So you can see the right adnexa shows a rounded structure. You can see here, there's a rounded structure that we're seeing there. Is this an ovarian cyst? Is that a dermoid? What is that? Can you spot it? Can you spot what I'm seeing there? What is that? The ovary, the right ovary. You can see that's the right ovary there. What is this? What is that? Look at it closely. What is this? What is that? What is this? In the right adnexa, this rounded structure there. Pause for a moment. Don't rush. Don't rush to report it. What is it? What is it? Rescan again. Zoom the image. What is that? Image 3. We have zoomed it nicely. A hyperechoic ring surrounding a gestational sac separate from the ovary. So you see on colored Doppler, you can see there's a ring there. There's a ring of fire. What is that? What is that? Is it a corpus luteum cyst? What is it? What can that be? On color Doppler, you can see here the hyperperfusion, the ring of fire around the cystic structure. What is this? Most people miss this. Most sonographers have missed this. Even now, 90% or above can still miss this. What do you think it is? How would you report this? How do you report this? That's where hurried reports get so disturbing. False reports are made. The life of patients is put at risk. So, let me explain the findings. Let me explain the findings. Did you get it right? Did you get it right? So the missed ultrasound sign is the tubal ring sign. This subtle echogenic ring is one of the most reliable early ultrasound signs of tubal ectopic pregnancy. So this is not just an ectopic pregnancy, it's a tubal ectopic pregnancy. Many beginners mistake for corpus luteum cyst, small ovarian cyst, or normal adnexal tissue. So you must be very meticulous. You should have the eyes of an eagle for you to be able to pick these silent or subtle pathologies, especially in early stages. And these are included here. Why? Because it overlaps with a gynecological ultrasound. A first trimester obstetric scan overlaps with a gynecological ultrasound because most patients, they come to the department unsuspecting that they are pregnant. So these are the incidental findings that every sonographer should have in their fingertips. We should expect that a person comes, some they even lie. I am not sexually active. When you do an ultrasound, you find those surprises. So you must be very vigilant when it comes to these cases. So the key teaching points: the tubal ring is separated from the ovary. It is thick echogenic wall, often contains a tiny gestational sac. Color Doppler may demonstrate the ring of fire, although this is not specific, as corpus luteum can also show peripheral vascularity. So we are saying the major distinction between a corpus luteum cyst and a tubal ectopic pregnancy is it should be separated from the ovary. We see a distinct ovary and you see the tubal ring. But the corpus luteum cyst will be inside the ovary itself. So here you must be very, very careful. Just be very careful. So color Doppler may demonstrate the ring of fire, but the ring of fire, you can also see it in a corpus luteum. So if you see a ring of fire, it doesn't imply that it's an ectopic pregnancy automatically. It's an overlap. It overlaps between the two. So you have to use other markers, the pregnancy test, at the same time, the separation of the tubal ring with the ovary. So what's the final diagnosis in this case? What is it that is missed? It is a tubal ectopic pregnancy. Ladies and gentlemen, we should make an effort not to miss a tubal ectopic pregnancy. You must correlate your findings with the pregnancy test. So now let's take a quick quiz for this session. I need us to debate it on the comment section, under the comment section in our usual YouTube medical ultrasound channel. Which ultrasound sign was the key diagnosis? Sliding sign, double zero sex sign, tubo-ovarian sign, or pseudo gestational sac? Which one is it? Which ultrasound was the key diagnosis? Sliding sign, A, B, double zero sign, C, tubo-ovarian sign, D, pseudo gestational sac. So type your results in the comment section and let's debate about it. Question number 2. Which feature helps distinguish a tuber-ectopic pregnancy from a corpus luteum cyst? A. Peripheral vascularity. B. Thick wall. C. Separate from the ovary. D. Anechoic appearance. Which feature helps distinguish a tuber-ectopic pregnancy from a corpus luteum? A. Peripheral vascularity. B. Thick wall. C. Separate from the ovary. D. Anechoic appearance. So now, what is the clinical pill? What is the clinical pill? Never diagnose an ectopic pregnancy based on the ring of fire alone. Always identify whether the lesion is separate from the ovary and correlate with the patient's clinical presentation of beta HCG levels. This is your Bible. This is your take home. That's the clinical pill. Never diagnose an ectopic pregnancy based on the ring of fire alone. Always identify whether the lesion is separate from the ovary and correlate with the patient's clinical presentation in the beta HCG levels. Ending. Thousands of sonographers scroll past this tiny ultrasound sign every year, but missing it can have life-threatening consequences. Train your eyes to recognize it early, and you will never forget it again. If you spotted the tubo-ovarian sign before the reveal, let me know in the comments. Please, let's make it exciting. Who saw it before I reveal to you? Just type in the comment section, I saw it. If you didn't know about it, also be honest. Say that you didn't know, so that we know the areas which we need to polish up, the areas which we need to keep improving. Ladies and gentlemen, thank you so much. Enjoy the rest of your day. Don't forget to subscribe to our channel, and also don't forget to comment under the comment section. Thank you. Medical ultrasound is the greatest gift from God to mankind, but sometimes making the right diagnosis poses a dilemma. So let's unpack the sonographic dilemmas that we can find during our examinations. So here I'm going to explain the answers to our ovarian pathology quiz session that we've done. So let's go straight into question number 1. A 28-year-old woman presents with pelvic pain. Transvaginal ultrasound shows a 4 cm ovarian cyst with fine internal echoes and a fishnet or reticular pattern. No solid components on Doppler flow within the echoes. What is the most likely diagnosis? So you can see this is our lesion there in the ovary, and this is what we call the fishnet or reticular pattern. So this fishnet or reticular pattern is a sonographic sign of fibrin strands of blood. So this is fibrin strands of blood which confers this configuration, the so-called fishnet appearance. So this is in keeping with a hemorrhagic corpus luteum cyst because blood confers the fishnet appearance that we are seeing. So this is not a serious cystadenoma. This is not a mature teratoma.
it's not an endometrioma, this one. So this is what you call the reticular pattern. So if you see these septations there, which are echogenic like that inside the cyst, this is highly suggestive of a hemorrhagic cyst. You can also see what is called a retracted clot in a hemorrhagic cyst. Question number 2. Which ultrasound feature is most characteristic of an endometrioma, the chocolate cyst? A. Posterior acoustic enhancement with thin walls. B. Homogeneous low-level internal echoes, the ground glass appearance. C. Fatty fluid levels with bright echoes. D. Multilocular mass with the papillary projections. So this is a typical characteristic of an endometrioma, which is a chocolate cyst. So the morphology of an endometrioma is what is referred to as the ground glass appearance. So this is what differentiates an endometrioma from other ovarian lesions. So it's homogeneous, low level internal echo. So they are homogeneous. You can see that they are homogeneous there, they are homogeneous, and then this internal echoes. So this is ground glass appearance. So our answer is B. Question number 3. A dermoid plaque, the rocking task nodule, is a classic finding in which ovarian lesion? So this is our ovarian mass lesion there. Then you can see here what we have here. This is the echogenic nodule there that is called the rocking task nodule. So you can find some internal debris in the dermoid cyst there that is called the dermoid mesh. So this rocking task nodule gives a posterior acoustic shadow. So the configuration is now what we call the tip of the iceberg sign. So A, hemorrhagic cyst. B, mature cystic teratoma, which is the dermoid. Then C, mucinous cystadenoma. D, thicker lutein cyst. So the morphology of a dermoid plaque, the rocking task nodule, we find it in a mature cystic teratoma, which is the dermoid. Question number 4. A post-menopausal woman has a 6 centimeter unilocular, thin-walled ovarian cyst with no internal echoes or solid components. What is the most appropriate next step according to common guidelines? A post-menopausal woman has a 6 centimeter unilocular, thin-walled ovarian cyst with no internal echoes or solid components. So this is a sign that this is a benign lesion, is not malignant. So what is the most appropriate next step according to common guidelines? A, immediate surgical removal. B, follow-up ultrasound in 6 to 12 months. C, no follow-up needed if less than 5 centimeter. D, color Doppler to assess for neovascularity. So all these cysts, they should be followed up. So the correct answer is follow up ultrasound in 6 to 12 months. So that's the recommendation that you have to give when you see such a cyst. Yes, postmenopausal, and it's non-cancerous, it's benign. So you just have to follow up in 6 to 12 months. Question number 5. Which finding is most suggestive of an ovarian torsion on ultrasound? So ovarian torsion is when the ovary twist. So enlarged ovary with peripheral follicles and absent Doppler flow. B, ground glass appearance with low level internal echoes. C, string of pure sign. D, thick septations with color flow. So here is an ovarian torsion. You can see that the ovary is enlarged, is demarcated, and there's no internal flow on Doppler. Compared to the contralateral side, you can see there's flow there on ultrasound, there's no flow here. So the correct answer for ovarian torsion is A, enlarged ovary with the peripheral follicles and absent Doppler flow. So that's the correct answer. Number 6. A patient with infertility shows bilateral enlarged ovaries greater than 10 cubic centimeters with over 20 small follicles which are 2 to 9 millimeters arranged peripherally. What is diagnosis fees benefits? Fees best. A. Bilateral dermoids. B. Polycystic ovarian morphology PCOM. C. Bilateral endometriomas. D. Ovarian hyperstimulation syndrome. So you can see the morphology there. We've got this multiple cysts there and the ectopic stroma. So this is a morphology of polycystic ovarian morphology PCOM. If ovaries are enlarged above 10 cubic centimeters with above 20 small follicles 2 to 9 millimeters in diameter, so that's polycystic ovarian morphology. Question number 7. A complex cystic mass with multiple thin septations, no solid nodules, and low level echoes is seen. What is the most likely benign diagnosis? So we have got the lesion there. You can see the multiple septations. They are just these tiny little internal low level echoes there. So this is a serous adenoma, mucinous cystadenoma, mature teratoma, and borderline tumor. So the correct answer is mucinous cystadenoma. When you're talking about a serous cystadenoma, serous is fluid, so it should be fluid, anechoic fluid, without the septations and without the internal low-level echoes. So mature teratoma, you should have a dermoid, and then the borderline tumor is supposed to be malignant transformation with internal vascularity on Doppler. Question number 8. Which feature raises highest concern for malignancy in ovarian mass on ultrasound? Which feature raises highest concern for malignancy in ovarian mass on ultrasound? So you see, we have got a mass there, and you can see there are internal papillary projections, and there is this solid mass within the cystic lesion, and there is internal flow on power Doppler. So A, solid papillary projections with vascular flow. B. Homogeneous low-level echoes. C. Posterior acoustic shadows from calcifications. D. Unilocular simple cysts less than 5 centimeters. So the correct answer is, if you see a cystic lesion in the ovary with internal flow in solid components, that is highly suggestive of malignancy, which is cancer. So the correct answer is solid papillary projections with vascular flow. That's our correct answer, A. Question number 9. A pregnant patient on fertility drugs develops bilateral enlarged ovaries with multiple large cysts. What is this condition? So you can see here are the large follicles there that is developed. So this is due to hyperstimulation of the ovary by the fertility medication drugs. A. Endometriomas. B. Thecal uterine cyst hyperratio luteinalis. C. Bilateral hemorrhagic cyst. D. Cancerous big tumors. So the correct answer is because of the hyperstimulation by the pregnancy medication, the answer is thecal uterine cyst, which is called the hyperratio luteinalis. That's the morphology. Question number 10. A 35-year-old woman has a para-ovarian cyst on ultrasound. Where is it typically located relative to the ovary? So you can see the ovaries here, and you can see the para-ovarian cyst is there. A. Within the ovarian stroma. B. Separate from the ovary, often in the broad ligament. C. Posterior to the uterus. D. Adherent to the fallopian tube, fimbria. So the correct answer is separate from the ovary, often in the broad ligament. That's why it is called para. Para is on the para side. So it should be separate from the ovary, often in the broader ligament. So ladies and gentlemen, this is the end of our quiz presentation. These are the answers. Congratulations to all those who got the answers very correct. So to those who missed, I think this is your chance to learn. Add every pathology to your vocabulary of learning to improve your practice. Thank you so much. Let's meet again in the next quiz session. Enjoy the rest of your day. Today, let's discuss on a surgical dilemma, the forgotten sponge, a fascinating ultrasound case. So the case structure. Today's patient was told she had a large abdominal tumor. Multiple scans raised concern for malignancy, but ultrasound revealed something completely unexpected. Before I reveal the diagnosis, study these images carefully and ask yourself, what is your diagnosis? Stay until the end because this case teaches one of the most important post-operative complications every sonographer should recognize. The case introduction. Patient history, age, 42-year-old female, chief complaint, progressive abdominal pain, lower abdominal swelling, occasional fever, weight loss, and early satiety. The patient history, cesarean section was done 5 years ago. Open hysterectomy was done 2 years ago. Persistent abdominal discomfort since surgery, no known malignancy. Clinical examination, physical findings, palpable lower abdominal mass, mild tenderness, no signs of acute peritonitis, stable vital signs. So question that you need to ask, what would be your differential diagnosis? So as a sonographer, as a radiologist, when you get the history of a patient, you must start to have something at the back of your mind. What could it be before you even do the scan? A, ovarian neoplasm. B, an abscess. C, mesenteric cyst. D, gossipy boma. So here are the ultrasound findings. Scan technique that was done. Curvilinear probe was used. Longitudinal and transverse scans and color Doppler evaluation were done. So the image findings. So see what we found there in the pelvis. So we are seeing this pelvic lesion, the pelvic mass that we have here. Look at it closely. What is it, guys? What is that? Look at it closely. You can see there is acoustic shadows there, shadowing there, acoustic shadowing, and there's a lesion there. Within the lesion, you can see there are these echogenic structures which looks like calcifications. What do you think this is? What do you think that is? So the findings, a large heterogeneous mass, approximately 12 by 10 by 9 centimeters. Characteristics, well-defined margins, thick echogenic capsule, mixed echogenicity, internal wave hyperechoic linear structures, multiple bright curvilinear echoes, dirty posterior acoustic shadowings, trapped internal air, no internal vasculature and Doppler, mild surrounding inflammatory changes, adjacent bowel loops displaced, and there is no ascites. So what do you think this is? Let me go over the findings again. Heterogeneous mass, you can see the mass is heterogeneous there. It measures approximately 12 by 10 by 9 centimeters, sorry. So the characteristic of this mass is a well-defined margin. You can see the margins are well-defined there. Then you can see there's a thick echogenic capsule. So the capsule is there, is thick and it's echogenic. And then there's mixed echogenicity within the mass. You can see that there's mixed echogenicity. There are areas which appear as if there's fluid there. Then there's also the solid component that you're seeing, the echogenic ones. Internal wave hyperechoic linear structure. So the linear structures there, they've got a wavy pattern, the wave pattern there. You can see the wave pattern there. So with the multiple bright curvilinear echoes, so those are bright echoes, which you can see there. Dirty posterior acoustic shadowing. So you can see this dirty posterior acoustic shadowing that you are seeing here, that you can appreciate there. Trapped internal air. So there's also trapped internal air There's air that is trapped. You can see this dead shadow due to trapped air. No internal vascularity on Doppler. Mild surrounding inflammatory changes. Adjacent bowel loops displaced. No ascites. So there's no ascites in the surrounding areas there, in the surrounding region adjacent to the lesion. So pause again. What diagnosis came to your mind? What is coming to your mind? Look at the lesion nicely again. What are you going to report on? You are the sonographer. You are the radiologist who has done this sonar. How are you going to report it? What do you think this is? Marry this one to the history of the patient. What do you think that could be? The diagnosis. This is a gossipy boma, which is also called a textaloma, retained surgical sponge following previous surgery. So a retained sponge following surgery is what is called the gossip boma or a textaloma. Did you know this about this before? Is this your first time to hear about it? If it's the first time, for how many years have you been scanning? Did you miss it at one point, or you don't remember? Let's explain the ultrasound findings. Classic sonographic appearance of a gossip boma, well-defined encapsulated mass, represents the fibrous capsule formed around the retained sponge. Number 2, wavy echogenic internal stripes. The folded cotton fibers produce characteristics undulating echogenic lines. This is one of the most important ultrasound signs. Dirty acoustic shadow due to the air occurs because air becomes trapped within the sponge fibers. 4. Complex heterogeneous appearance results from fibrosis, granulation, tissue, fluid, blood, air, and the cotton material. So let me repeat again the sonographic signs of a gossip boma or a textaloma. Well-defined encapsulated mass represent the fibrous capsule formed around the retained sponge. Wave echogenic internal stripes. The folded cotton fibers produce characteristics undulating echogenic lines. This is one of the most important ultrasound signs. Dirty acoustic shadow occurs because air becomes trapped within the sponge fibers. Complex heterogeneous appearance results from fibrosis, granulation, tissue, fluid, blood, air, and the cotton material. Absent vascularity, color Doppler typically demonstrates no internal blood flow on a gossip boma. Now let's talk about the pathophysiology of a textaloma. Retained surgical material produces two possible reactions. One, exuded reaction leads to abscess formation, infection, fistula formation, usually presents early. And then we also have got aseptic fibrotic reaction produces foreign body granulation, granuloma, encapsulation, slowly enlarging mass, may remain undetected for years. So we are saying this is the pathophysiology of a textaloma, which is the retained surgical material. It produces two possible reactions, exudate reaction and aseptic fibrotic reaction. So those are the two reactions that can form. So as a sonographer or a radiologist, you must have this at the back of your mind. You are looking at the possible reactions of a possible foreign body, the textaloma, which is exudate reaction and aseptic fibrotic reaction. So now when you're doing a sonar, you're looking for the signs of an abscess, infection, fistula formation, which are the early formations. Then later on in chronic stages, you can see a foreign body granuloma, encapsulation, slowly enlarged mass. So these are the things that you must be on the lookout for. You don't just scan anyhow without understanding the pathophysiology of certain conditions that you are likely to meet when you're doing your ultrasound scan. So what are the differential diagnoses now when you see a mass that looks like a gossip boma on ultrasound, disease, ovarian tumor, abscess. So this ovarian tumor has got internal vascularity and solid components. Then abscess, it has got thick walls, debris, and hyperemia. Then hematoma evolves over time, lacks wavy internal echoes. Then hydantic cyst, daughter cyst, and calcifications are present. Then necrotic lymph node, rounded with peripheral vascularity. Then the fibroma, wavy echogenic stripes, dead shadow with no Doppler flow in the history of a previous surgery. So, ladies and gentlemen, this is one of the cases which presents a surgical dilemma to most surgeons. Imagine you've done your surgical operation procedure, then your patient keeps on coming to say that I'm feeling pain, I'm feeling pain. You'll be wondering what is going on. And imagine the panic when you realize that I left something, a foreign body in a patient body, and your reputation. So we are talking about one of the serious post-surgical complications that also you as a sonographer or radiologist must not miss. So you equally complicate the dilemma if you miss the ghost bomb again, because it can cause those reactions, and it can be so bad for the patient, or the patient can eventually die. Thank you so much, ladies and gentlemen. Don't forget to subscribe to our channel and share your comments with us. Any improvement that you need us to make, we would really appreciate. Thank you so much. The sonographic appearance is the blueprint that we use to come up with a diagnosis. So let's talk about advanced pelvic ultrasound quiz. So this one for experts, those people who have been in the game for quite some time. They are the ones who are going to perform better in this quiz session. So let's go to question number 1. A 34-year-old woman presents with chronic pain and infertility. Ultrasound shows enlarged ovary, homogeneous low-level internal echoes, thick walls, no internal vascularity, multiple peripheral follicles. What is the most likely diagnosis? Let me come again. A 34-year-old woman presents with chronic pelvic pain and infertility. Ultrasound shows enlarged ovary, homogeneous low-level internal echoes, thick walls, no internal vascularity, multiple peripheral follicles. What is the most likely diagnosis? A. Hemorrhagic cyst. B. Endometrioma. C. Dermoid cyst. And D. Tubo-ovarian abscess. So, what is the most likely diagnosis? Hemorrhagic cyst, endometrioma, dermoid cyst, or tubo-ovarian abscess. Question number 2. A pelvic mass demonstrates highly echogenic mural nodule, posterior acoustic shadowing, echogenic lines and dots, fed fluid level. What is the diagnosis? A pelvic mass demonstrates highly echogenic mural nodule, posterior acoustic shadowing, echogenic lines and dots, fed fluid levels. What is the most likely diagnosis? A. Serous cystadenoma. B. A dermoid cyst. C. Hemorrhagic cyst. D. Endometrioma. Question number 3. A post-menopausal woman has thick, irregular endometrium, 16 millimeters thick, increased vascularity, endometrial myometrial junction poorly defined. What is the most likely diagnosis? A. Endometrial hyperplasia. B. Endometrial carcinoma. C. Endometrial polyp, and B. Submucosal fibroid. A post-menopausal woman has thick irregular endometrium measuring 16 millimeters, increased vascularity, endometrial-myometrial junction poorly defined. What is the most likely diagnosis? Endometrial hyperplasia, endometrial carcinoma, endometrial polyp, or a submucosal fibroid. Question number 4. A patient presents with severe acute pain. Ultrasound demonstrates a large ovary 9 centimeters, peripheral follicles, minimum venous flow, no arterial flow, Whirlpool sign. What is the most likely diagnosis? A patient presents with severe acute pelvic pain. Ultrasound demonstrates enlarged ovary 9 centimeters, peripheral follicles, minimum venous flow, no arterial flow. Whirlpool sign. What is the most likely diagnosis? A. Ruptured cyst. B. Ovarian torsion. C. Pelvic inflammatory disease. D. Endometriosis. So, what is the most likely diagnosis? A patient presents severe acute pelvic pain. Ultrasound demonstrate enlarged ovary 9 centimeters, peripheral follicles, minimum venous flow, no arterial flow, and the Whirlpool sign. Question number 5. Ultrasound reveals a multiple loculated cystic adnexal mass with thick septations, papillary projections, internal vascularity, and moderate ascites. What is the most likely diagnosis? A ultrasound reveals a multiloculated cystic adnexal mass, thick septations, papillary projections, internal vascularity, and moderate ascites. What is the most likely diagnosis? A. Mucinous cystadenoma. B. Serous cystadenoma. C. Epithelial ovarian carcinoma. D. Hydrosalpinx. So which one is the most likely diagnosis? Multiloculated cystic adnexal mass, thick septations, papillary projections, internal vascularity, moderate ascites. What is the most likely diagnosis? A. Mucinous cystadenoma. B. Serous cystadenoma. C. Epithelial ovarian carcinoma. D. Hydrosalpinx. Question number 6. A patient presents heavy menstrual bleeding. Ultrasound demonstrates globular uterus, heterogeneous myometrium, fan-shaped shadowing, myometrial cyst, and thickened junctional zone. What is the most likely diagnosis? A. Fibroids. B. Adenomyosis. C. Endometrial polyp. D. Leiomyosarcoma. A patient presents heavy menstrual bleeding. Ultrasound demonstrates globular uterus, heterogeneous myometrium, fan-shaped shadowing, myometrial cyst, thickened junctional zone. What is the most likely diagnosis? Fibroids, adenomyosis, endometrial polyp, leiomyosarcoma. Question number 7. Ultrasound demonstrates a tubular cystic structure with incomplete septa, with the waist sign, cogu appearance, no internal vascularity. What is the most likely diagnosis? Ultrasound demonstrates a tubular cystic structure with incomplete septa, the waist sign, cogu appearance, no internal vascularity. What is the most likely diagnosis? A. Para-ovarian cyst. B. Hydrosalpinx. C. Ovarian cyst. D. Pylosalpinx. Let me come again. Ultrasound demonstrates a tubular cystic structure with incomplete septa, waist sign, cogwheel appearance, no internal vascularity. What is the most likely diagnosis? A. Para-ovarian cyst. B. Hydrosalpinx. C. Ovarian cyst. D. Pyosalpinx. Question number 8. A first trimester pregnant has empty uterus, adnexal gestational sac, live embryo with cardiac activity, moderate free fluid in the pelvis. What is the most likely diagnosis? A first trimester pregnant woman has empty uterus, adnexal gestational sac, live embryo with cardiac activity, moderate free pelvic fluid. What is the diagnosis? A. Pregnancy of unknown location. B. Uterotopic pregnancy. C. Tubo-ectopic pregnancy. D. Corpus luteum. A pregnancy of unknown location. B. Heterotopic pregnancy. C. Tubo-ectopic pregnancy. D. Corpus luteum. What is the most likely diagnosis? Question number 9. A large uterine mass demonstrates rapid interval growth, irregular margins, marked central vascularity, areas of necrosis. Most concerning diagnosis is what? Degenerating fibroid, leiomyoma, leiomyosarcoma, and adenomyosis. A large uterine mass demonstrates rapid interval growth, irregular margins, marked central vascularity, and areas of necrosis. What is the most likely diagnosis? A. Degenerating fibroid. B. Leiomyoma. C. Leiomyosarcoma. D. Adenomyosis. Question number 10, which is the last one. A woman undergoing infertility wake up is ultrasound findings of 2 separate endometrial cavities, deep external fundal cleft above 1 centimeter, widely divergent uterine wounds. What is the most likely diagnosis? A woman undergoing infertility wake up is ultrasound findings of 2 separate endometrial cavities, deep external fundal cleft greater than 1 centimeter, widely divergent uterine horns. What is the most likely diagnosis? A. Septate uterus. B. Arcuate uterus. C. Biconate uterus. D. Dideves uterus. A woman undergoing infertility wake up is the ultrasound findings of 2 separate endometrial cavities, deep external fundal cleft above 1 centimeter, widely divergent uterine horns. What is the most likely diagnosis? A. Septate uterus. B. Arcuate uterus. C. Biconate uterus. D. Dideves uterus. Ladies and gentlemen, all the best in our quiz session. We will come again with the answers and explanations. For now, enjoy your quiz session. Type your responses in the comment section and let's engage. Thank you so much. How do you write a report for ultrasound hematometria? How do you do it? See how I do it myself. So, ultrasound case report challenge, hematometria, can you spot the diagnosis? The clinical history, in my case, a 27-year-old woman presents with progressively worsening cyclic lower abdominal pain, secondary amenorrhea for 5 months, and pelvic fullness following a previous cervical procedure. A pelvic ultrasound is requested. So, ultrasound report, examination trans-abdominal and trans-vaginal pelvic ultrasound was performed. The clinical indication, amenorrhea, severe cyclic pelvic pain, suspected outflow tract obstruction. So these are the findings. So this is the endometrial cavity. You can see here that the endometrial cavity is distended and there is some fluid there with low level internal echoes inside. You can see part of the os is also open and then distended. So you can see here again in transverse, you can see that the endometrial cavity is very much distended and the uterus appears very much enlarged due to the collection in the endometrial cavity. How do you report this case? So reporting is fundamental. It is key, is the language that we use to communicate with someone who is not present. The referring clinician is not with you when you are doing the sonar. So how do you communicate your findings? So that is the fundamental part of every ultrasound scan. So the findings, this is how I do it. The uterus is antevated and mildly enlarged, measuring approximately 9.8 by 6.5 by 7.2 centimeters. The myometrium demonstrates homogeneous ecotexture with no focal fibroids. The endometrial cavity is markedly distended by a large volume of complex fluid measuring approximately 4.8 centimeters in maximum AP diameter. The endometrial cavity itself, let us expand it. The cavity contains heterogeneous echogenic fluid with numerous low-level internal echoes. The ground glass appearance consistent with retained blood products. Fine echogenic debris and layering echoes are present. No internal vascularity is demonstrated on color Doppler imaging, excluding a vascular endometrial mass. So mild fluid levels are visualized, suggestive of blood or varying ages. No intrauterine gestational sac is identified. So let's continue with the findings. Now the cervix. The cervical canal appears markedly narrowed, obstructed, with minimum communication between the uterine cavity and vagina. No cervical mass is identified. Findings are compatible with cervical stenosis likely causing obstruction of menstrual flow. So the ovaries, the right ovary measures 3.4 by 2.3 by 2.1 centimeters. Normal follicular pattern, normal arterial and venous blood flow. The left ovary measures 3.2 by 2.4 by 2.0 centimeters. Normal appearance, normal Doppler vascularity. So the adnexia, no adnexia masses identified, no sonographic evidence of tubo-ovarian abscess. Pouch of Douglas, no significant free fluid noted. So in color Doppler findings, no internal vascularity within the retained intracavitary material, normal uterine and ovarian perfusion. The impression, my impression is a large hematometria. What is yours? What's your impression if you see such type of sonographic finding? What is your impression? What do you think it is? Characterized by marked distension of the endometrial cavity, complex intracavitary fluid containing low-level echoes and blood clots, absence of internal vascularity, probable cervical obstruction or stenosis causing retention of menstrual blood, no evidence of endometrial malignancy, retained product conception, pelvic inflammatory collection, and adnexial pathology. So this is just how we elaborate our findings. That's an elaboration of the impression. So recommended correlation. So you also have to correlate the findings. So one, correlate the clinical pelvic examination with the pregnancy test, beta HCG, gynecological consultation, consider RMI if the level of obstructions are uncertain, therapeutic cervical dilatation and evacuation may be indicated depending on the underlying cause. So now, let's go to the learning points in this case. Typical ultrasound features of hematometria. So you have to understand the typical characteristics or the morphology of hematometria on ultrasound. A large uterus, distended endometrial cavity, complex echogenic fluid, low-level internal echoes, the characteristic ground glass appearance. So this is the ground glass appearance. Fluid levels from layered blood products. So you normally see that there will be different layers within the endometrial cavity when there is hematometria due to different ages of blood collecting, old blood, new blood that is accumulating. So they will have different layers. So blood clots within the cavity. So the clots can also form. Then no internal Doppler flow. And then possible cervical stenosis or obstruction lesion. So you can see a stenosis or lesion that is obstructing the cervix on ultrasound. So now let's just do this case challenge quickly. A young woman presents with severe monthly pelvic pain and amenorrhea. Ultrasound reveals a massively distended endometrial cavity filled with complex echogenic material, but no blood flow on Doppler. What is the most likely diagnosis? A. Pyometria. B. Endometrial carcinoma. C. Hematometria. D. Retained products of conception. A woman hasn't had a period for 5 months, but the uterus is full. What is the most likely diagnosis? So this type of small history must capture everything. The moment that a patient is referred to you with such type of brief histories, at the back of your mind, you should also start to think about hematometria. That's a good possibility. That's a good possibility. You have to think about it. So the clinical appeal, you take home. Hematometria should be suspected in patients with cyclic pelvic pain, amenorrhea, and a distended endometrial cavity containing avascular echogenic fluid. The most common causes include cervical stenosis after surgery, congenital outflow tract anomalies such as an imperforate hymen or transverse vaginal septum. Radiation therapy or obstructing cervical lesions are the other causes of hematometria. So prompt diagnosis is important because untreated hematometria can lead to infection, pyometria, endometriosis from retrograde menstruation, infertility, and chronic pelvic pain. Ladies and gentlemen, let me repeat again the clinical appeal. So this is very critical. You must just jot this down and just have somewhere a space in your memory where you have to keep it and remember it for the rest of your life. Hematometria should be suspected in patients with cyclic pelvic pain, amenorrhea, and a distended endometrial cavity containing avascular echogenic fluid. The most common causes include cervical stenosis after surgery, congenital outflow tract anomalies such as an imperforate hymen or transverse vaginal septum, radiation therapy or obstructing cervical lesions. Prompt diagnosis is important because untreated hematometria can lead to infection, which is pyometria, endometriosis from retrograde menstruation, infertility, and chronic pelvic pain. So this marks the end of this case presentation. Ladies and gentlemen, this is how I write my report. I don't know how you do it. This is just a simple report. Remember, again, every Friday and Wednesday, we do post a simple report writing cases. Then remember also on Monday, on Tuesday, on Thursday, on Friday, we also post our normal case discussion on real cases for discussion. Then we've got our everyday challenge for the quiz sessions. These are the things that will make you to master a medical ultrasound. So take them seriously. If you've got any questions, feel free. You can ask under the comment section. Enjoy the day.
How are you, good people? I hope you're doing very well, and I hope learning is progressing well as well. So in this presentation, I am going to talk about a compilation of uterine congenital anomalies. By the way, my name is Last. So uterine congenital anomalies on ultrasound. Congenital uterine anomalies, CUAS, also known as Mullerian duct anomalies, are developmental abnormalities resulting from abnormal formation, fusion, or resorption of the paired Mullerian ducts during fetal development. These anomalies may affect fertility, pregnancy outcomes, menstruation, and pelvic pain. Ultrasound, particularly 3D transvaginal online imaging modality for diagnosing uterine anomalies due to its excellent visualization of the uterine cavity and external fundal contour. So the embryology of the uterine development. So the female reproductive tract develops from the paired Mullerian ducts between the 16th and the 12th weeks of gestation. Development involves three important stages: formation of both Mullerian ducts, fusion of the ducts, resorption of the central septum. Failure during any stage results in different uterine anomalies. The classification of the uterine anomalies, the major congenital uterine anomalies include agenesis or hypoplasia, uniconvert uterus, uterine diadeus, biconvert uterus, septate uterus, arcuate uterus, and complex anomalies. So let's start by talking about the Mullerian agenesis MRKH syndrome. So Mullerian agenesis, by definition, is failure of uterine development. So ultrasound findings: absent uterus, small rudimentary uterine buds may be seen, normal ovaries, normal kidneys should also be assessed because renal anomalies are common. Clinical presentation: primary amenorrhea, normal secondary sexual characteristics, and infertility. So the second one is what is called uniconvert uterus. By definition, one Mullerian duct develops normally while the other fails partially or completely. Ultrasound findings: we will see a small banana-shaped uterus, single endometrial cavity, deviated uterus, rudimentary horn may be present, reduced uterine volume. So on 3D acquisition, excellent for demonstrating single uterine horn, external fundal contour, or rudimentary horn. So the associated findings: renal agenesis, commonly ipsilateral, meaning it says on one side, rudimentary horn pregnancy, endometriosis, pregnancy risks, miscarriage, preterm birth, malpresentation, ectopic pregnancy in rudimentary horn. So here are the images which shows how a uniconvert uterus appear like. So you see here we have got a fallopian tube there. There's no other another fallopian tube on the other side. So it's only this one that is developed, and you can see there is one ovary on that side and the cervix here. So this side there's nothing. So you can see again there we have uniconvert and again a uniconvert. So look how it appear like on 3D. It appear like a banana like that. That is how a uniconvert uterus appear like. On 2D, you can see how it appears like that, like elongated like that, appearing like a banana. Look at it again. This is how a uniconvert uterus present like or appear like. So we also have got a third one, which is the uterine diadelphs. By definition, which is the complete failure of Mullerian duct fusion. So ultrasound findings: two completely separate uterine cavities, two uteri fundi, two cervices, sometimes double vagina. 3D findings: deep fundal cleft, completely separated uterine holes. So the clinical features: recurrent miscarriages, dyspareunia, obstructed hemivagina occasionally. So these are the sonographic findings of uterine diadelphs. So you can see we've got one uterus there, we've got another uterus there, the cervix there, and the cervix there, which are distinct, which are separate. So you look at it again, you've got the right uterus and the left uterus there, the right uterus there, the left uterus there, right uterus there, left uterus there. So you can see here we are seeing two distinctive uteruses. So this is in keeping with uterine diadelphs. The fourth one is biconvex uterus. So by definition, this is partial fusion of the Mullerian ducts. Ultrasound findings: heart-shaped uterus, two endometrial cavities, deep external fundal indentation above 1 centimeter, single cervix, biconvex unicornis, occasionally two cervices. So on 3D ultrasound, base demonstrate external fundal cleft, diverging uterine horns. So the risks in pregnancy: miscarriage, breech presentation, preterm labor. So here, this is how a biconvex uterus appear like. So you can see a serosal indentation there. There's a serosal indentation there, and then this is the uterus there. So look at this one. We've got a serosal indentation there. Then we have got these two horns like that, and then you can see the two cavities there. So the two cavities are there. The two cavities are there. There's an indentation there. There's an indentation there. You can see one of the horns is pregnant there. That's a gestational sac, and then the other one there. So this is a biconvex uterus. In it has got a serosal indentation there. So the other one is septate uterus. So by definition, failure of septal resorption after normal Mullerian duct fusion. This is the common congenital uterine anomaly. Ultrasound findings: normal external fundal contour, fibrous or muscular septum dividing the cavity, single uterine fundus. So on 3D ultrasound, the gold standard technique because it clearly demonstrates normal uterine contour, internal septum. So the clinical significance of a septate uterus: highest association with recurrent miscarriages, infertility, and early pregnancy loss. So you see, the justification for us to study these uterine anomalies is some patients, they will be presenting with infertility, so you have to look religiously for any sign of uterine agenesis anomalies. So see here the septate uterus. So you can see here, that's this one, that's a normal uterus there. There you see, so there's a septum there. That is, you see, this is a normal uterus, and you can see there is a septum there that is dividing the two sides of the cavity like that. So you can see there's a septum there that is dividing the two cavities, and then the cavity, there's a septum that is in between there, a septum in between, a septum in between. So look here, we do have got the uterine cavities, then there's a septum in between there, and then again there's a septum there that is dividing the cavity into two, like that. So this is in keeping with a septated uterus. This is septate uterus. So we also have got what is called the arcuate artery, the arcuate uterus. So the arcuate uterus, sorry. So by definition, mild indentation of the uterine cavity, ultrasound findings: smooth external contour, small fundal indentation, broad cavity. Clinical significance: usually considered a normal anatomical variant. Most women have.
normal fertility, and normal pregnancy outcomes. So, ultrasound techniques. So, the preferred examination is transvaginal ultrasound, 3D ultrasound, coronal uterine plane, color Doppler when required, scanning during secretory phase, the mid-cycle. These phases provide optimal visualization of the endometrium. Row of 3D ultrasound advantages include displays the coronal uterine plane, differentiate septate from biconate uterus, measures fundal indentation accurately, improves surgical planning, and reduces need for invasive investigations. So here we have got our accurate uterus. You can see the indentation that we have there. This is a small indentation. So this is how it appears like. So you can see this is a small indentation there on the fundus of the uterus. This is a fluid filled uterus there. Then the accurate uterus, there's a small indentation there that we have there. That's a normal uterus like this. So there's no indentation on the cavity of a normal uterus, as you can appreciate or as you can see. So that's an accurate uterus. So they call this mostly an anatomical variant because it doesn't cause much problems or challenges in terms of fertility. So the key ultrasound measurements, so the measurement and interpretation, the external fundal indentation above 10 millimeters, it suggests biconate uterus. The normal external contour suggests septate uterus. Internal fundal indentation depth helps clarify anomalies. Interconal angle associates differentiate between biconate and septate uterus. So when you see these so-called uterine anomalies, congenital anomalies, you also must not forget the differentials. So there can be differentials that can mimic or resemble uterine congenital anomalies. So the differential diagnosis: adenomyosis, large subserosal fibroids, endometrial polyps, and intrauterine adhesions. Post-surgical uterine changes can also present or masquerade as uterine congenital anomalies. So, ladies and gentlemen, this brings us to the end of this presentation on uterine anomaly congenital abnormalities. So, I need you to appreciate these and add them to your vocabulary of pathologies so that when you're doing a pelvic ultrasound scan, you must be on the lookout for the congenital anomalies. Otherwise, you might pick a great finding that could be troubling a couple for years trying to get pregnant yet failing. Okay, so enjoy the rest of your day. I hope that you like this presentation. Don't forget to subscribe to the channel and put a like and also comment on the comment section. If any improvements that you need us to make, please let's communicate, let's talk. Thank you so much. Hello and welcome. So in this presentation, we are going to talk about uterine fibroids. There are different types. My name is Last. So what are uterine fibroids? Uterine fibroids, also called leiomyomas or myomas, are non-cancerous growths that develop in or on the uterus. They are common, especially during reproductive years, and are classified primarily by their location relative to the uterine wall, myometrium, endometrium inner lining, and the serosa, the outer lining of the uterus. So the main types of fibroids, simplified classification, we do have what called intramural fibroids. These grow within the muscular wall of the myometrium of the uterus. They are the most common type. They can enlarge the uterus and cause heavy bleeding, pelvic pain, or pressure. We also have what are called the subserosal fibroids. These develop on the outer surface of the uterus. Under the serosa, they may grow outward and can become large, sometimes pressing on the nearby organs like the bladder or bowel, leading to urinary or bowel symptoms. Submucosal fibroids, these grow just beneath the inner lining of the endometrium and protrude into the uterine cavity. They are less common but often cause the most symptoms such as heavy menstrual bleeding, prolonged periods, and fertility issues. We also have what are called the pedunculated fibroids. These are attached to the uterus by a stalk or the pentacle. They can be either subserosal on the outside or submucosal inside the cavity and may twist, causing acute pain. We also have got other less common locations of the fibroids. We have got the cervical fibroids in the cervix. We have got the parasitic fibroids, which is rare, detached, and getting blood supply from elsewhere. These are types of intramural fibroids, which are fibroids which are located within the myometrium. You can see here, these are the fibroids, these are the fibroids. This is the myometrium of the uterus, and you can see these are what we call the intramural fibroids. So you can see here in the cavity of the endometrium, you can see this bulge, the protrusion that we have. This is a intramural fibroid. You can see here, that's an intramural fibroid in the myometrium there. So a fibroid that you find within the myometrium, within the mass of the myometrium there, is called an intramural fibroid. We also got what called the subserosal fibroid. So the serosa is the outer lining of the uterus, this one. So those fibroids which dentures or which protrude outside like that are the ones which are called the subserosal fibroid. So you do have got this, a subserosal fibroid there. You see the subserosal fibroid there that is developing on the outer surface of the uterus. So on ultrasound, you can see this is the uterus there, this is the myometrium there, that's the endometrial cavity, and you see there's a fibroid here. So this is what we now call the subserosal fibroid. We have got the submucosal fibroids. So the submucosal fibroids are the fibroids which are developing also within the myometrium, but they are denting the endometrial cavity like that. You can see here they are protruding like that. So this is what we call the submucosal fibroid. The submucosal fibroid, you can see them there. You can see this multiple submucosal fibroid denting the lumen of the endometrial cavity. So on ultrasound, you can see this is the submucosal fibroid, and you can see it's denting on the endometrium. This is the uterus, this is the uterus there, and we have got a fibroid there. So this is a typical or a classical type of a submucosal fibroid. We also have got fibroids which are called the pedunculated fibroids. So you can see they are attached to the uterus. That's the uterus there with other multiple fibroids. And there's a stalk there, and you can see there's a fibroid that we have here. So this is what is called a pedunculated fibroid. So it's attached by a stalk to the uterus. These ones can cause acute pain when this stalk twists. So if they twist, it can cause pain. This is what we call a pedunculated fibroid. So when I do your sonar, do not just scan the uterus and forget to scan the adnexal region to check for pedunculated fibroids. So this is the uterus, and you have got a fibroid there attached by a stalk. So this is a pedunculated fibroid. So on ultrasound, you have got your uterus there, and you've got a stalk there. You can see there's blood flow that is going to supply the fibroid, the myoma there. So this is an example of a pedunculated fibroid, which is attached to the uterus via a stalk. So we also have, or can have, fibroids which are found within the cervix. So here you can see that this is your uterus there. It is also got multiple fibroids. You can see there are multiple fibroids there. But you also have got a stalk, and there's a fibroid that is there, which is also connected through a stalk. This is a pedunculated fibroid there that is going into the cervix. But we have got a fibroid there in the cervix. You can see this one in the substance or the mass of the cervix. So this is a cervical fibroid. So this is a uterus, and you can see this is the vaginal margin, and then you can see there's a huge fibroid there in the central part of the cervix. So this is a cervical or fibroid. So on ultrasound, this fibroid, you can see how it appear like with the our uterus there, and you can see there's a huge fibroid that we have here. So this is a type of a cervical fibroid. We also do have what are called the parasitic leiomyoma or the wandering fibroids. So a parasite is something that depends or that feeds on another tissue that is not its parent tissue where it is originally or coming from. So the parasite. So you can see here what we have. We've got a big fibroid there, and you can see there's the mesentery there. The mesentery, this is fat. So this one is giving the blood supply, a lot of blood supply from the mesentery there is attached to the mesentery. So this fibroid is not even attached to the uterus. It's just a wandering fibroid. So this is what we call, or what we refer to, parasitic leiomyomas. So these are parasite. It's a parasite because it's feeding from the vessels of the uh, mesentery like that. So you can see that here is the bowel there, the pelvic wall. This is got a parasitic fibroid there, which is not attached to the uterus. So why location matter when you are identifying or seeing the fibroids? The position affects the symptoms, e.g., submucosal often impact bleeding and fertility more, potential complications in treatment, options, medication, minimally invasive procedures like embolization or surgery. Size, number, and growth rate also play key roles. So note, fibroids are almost always benign. Consult a gynecologist for personalized evaluation, often involving ultrasound or MRI for accurate classification. Symptoms may vary widely. Many people have fibroids and no issues at all. So, ladies and gentlemen, this brings us to the end of our presentation on fibroids. I hope you understood the different types of fibroids that we have outlined or summarized. Don't forget to share this educational content with your colleagues and also subscribe for more educational lectures on this channel, on our YouTube channel. Thank you very much.
Hello, everyone, and welcome. So, I feel the best way of learning is to repeat. Repetition is the best way of learning. So, in this presentation, I am going to give a compilation of different or various uterine pathologies. So, we are going to have a compilation of all the pelvic pathologies. So we are going to do it stage-wise because there are too many. We can't do them all in a single presentation. So we are going to subcategorize these different pathologies. So let's start to discuss on uterine fibroids and their different manifestations and their sonographic appearances so that you can have an appreciation of the different types of fibroid that you can come across when you're doing your ultrasound studies. So here is your uterus, and then we have got different types of fibroids with different locations. So we can have what are called subserosal fibroids. So this one, the subserosa, so it dents on the serosa there. Then we can also have got a pedunculated submucosal fibroid. So a pedunculated fibroid can be in the inside of the uterus, in the intracavitary, or it can attach itself to the walls of the uterus, that will be outside. So we also got the submucosal fibroid. So that's the one that dents the endometrium like that. So that's a submucosal fibroid. Then you can also have the one that is found within the myometrium. Now this is called the intramural fibroid. So the one that dents the perimetrium like this is the submucosal subserosal fibroid, sorry. We also have another fibroid that is very difficult to distinct, that can stretch all the way from the subserosal part to the endometrial cavity there, like that, a big one. That's called a transmural fibroid. So here are different types of fibroids that we have. So we have got a very giant fibroid here. So you can see there's a thin margin between it and the rest of the walls of the uterus, but you can see that it's well outlined. If you follow this, you can see that it's a well outlined fibroid like that. And inside, you can see that it is heterogeneous. It is heterogeneous. When we say heterogeneous, we say that the tissue of the fibroid, they are not uniform. So some, they are bright areas here, there are darker areas there. But in terms of the composition, it's almost having the same echogenicity with the rest of the uterus like that. So this fibroid is almost isoechoic. So if you look at the back of this fibroid there, you can see that there is posterior enhancement, the brightness that we are having there. That is what is called the posterior enhancement. So a lesion or a mass that enhances posteriorly mostly is a sign that is a benign mass. So this is a fibroid. It's well outlined. It's not invading the surrounding tissues. It is having a mass effect. You can see this part of the uterus there is sort of pushed up, so that this is a mass effect of the fibroid. So this is one type of a fibroid that we have there. If we move here, that's our uterus there on transvaginal. So you can see the cervix there. There's a small cyst there. That's called the Napoleon cyst in the cervix there. So that's the endometrium. Then if you see here, there are multiple areas there. There are multiple areas there which are hypoechoic as compared to the rest of the uterus. But these ones can be confusing. So some people, they feel that, or they would think that these are fibroids. But to me, these ones are not fibroids. These are not fibroids. They can also be tiny fibroids like this, which are punctured like that. They can be fibroids as well. But to me, look here, you can see here, there's a cesarean niche there, meaning to say that this patient had a cesarean section. That's a cesarean scar there. And if you look at the endometrium closely, it is very much indistinct. It's very here, it sort of disappears, the endometrium there, and then we have these ones. So according to me, this is diffuse adenomyosis. This is diffuse adenomyosis. So you can have fibroids which are small, but these are not fibroids, but diffuse adenomyosis. So I need you to appreciate the sonographic appearance of those small tiny fibroids there. But they are not fibroids in this case because this patient has a history of a cesarean section and the endometrium is indistinct there, sort of disappearing. So here you cannot differentiate the myometrium from the endometrium here. So this is diffuse adenomyosis. We are going to discuss about adenomyosis in due course when we will be dealing with endometriosis. So now, again, here you can see that we are having a fibroid there, this lesion there. It has got bright margins. So this is in keeping with a calcifying fibroid. So this fibroid is sort of calcified. So if you look at the uterus well here, the uterus itself has got issues. It looks like it's also atrophic because if you look at it, these areas, they are very bright like that. And then there is another lesion mass here that is also appearing like another fibroid there. And you also got another fibroid there with a cystic portion there, which is showing signs of degeneration. So mostly after uterine embolization, you can have fibroids which start to die like this, or if they fail to have enough blood supply, they will start to die like that, and then you can see them calcifying or dying like that. So here you can see here there's a very large fibroid that we are seeing there. That's a very huge fibroid there. So if you look closely at the fibroid itself, it has got a different echogenicities. This area, it looks like another fibroid within a bigger fibroid. So it has got different, it's heterogeneous, but it's well outlined. As you can see that you can trace it nicely, and there is also posterior enhancement on the posterior aspect like that. So that's a fibroid, huge as it were. So you can see that it's having a mass effect on much of the uterus, and it's denting the endometrium. So this type of a fibroid that is huge like that and stretching all the way from around the from the serosa to the endometrium is called a transmural fibroid. That's a transmural fibroid. So again, we have got a giant fibroid here. You can see this one is well outlined. This one is a very much well outlined fibroid, and you can see that's our uterus there. That's another transmural fibroid. So it's having a mass effect on the surrounding structures. So these fibroids can really grow very big, even the size of your head. So they can be very big, and at times they can be confused with a pregnancy because the belly will bulge as if someone is also pregnant. So again, if you look here, you can see that's the uterus. Then this is the cervix. You can the cervical canal there. Then you can see this is the body of the uterus there, and you've got another huge fibroid, the Venetian blinds. So these lines that you are seeing here, this is what we call the Venetian blinds. So this is a fibroid, the whole of that. It's a well outlined fibroid. So you can see the problem with fibroids. Some of them, they will have almost the same echogenicity with the rest of the uterus. So they are sort of isoechoic, but if you look closely now, you can see that it's a mass. It's distinct from the rest of the mass, from the rest of the uterus, as you can see there. So that's another type of a transmural fibroid. So let's have a look here. You can see the uterus there, and you can see there is a fibroid there that is attached to this uterus. So this is a huge pedunculated fibroid. So there's a stalk, there's a connection between the fibroid itself and the uterus. So such type of fibroids are called pedunculated fibroids. These ones, mostly they cause excruciating pain. Why? Because at the stalk here, they can twist because there's a small narrow stalk that connects the two. So it can, because the uterus is also mobile, and the intestines and all that. So this thing can move and twist and cause sort of toes. When it happens, you can have excruciating pain from a pedunculated fibroid. So look closely here. You can see here there are multiple lesions, multiple lesions, multiple. So all of these ones. So these are multiple uterine fibroids. So this is one of the problems in gynecology, because imagine if a gynecologist is going to do myomectomy to remove all these fibroids, they have to cut all these pockets like that, all those pockets. So these ones, they are very complicated to manage. At times, the only remedy could be a total hysterectomy where they remove the whole uterus. Okay, because you can see they are very diffuse, multiple uterine fibroids. So look here, that's our uterus there. You can see here there's a fibroid there, and this is the canal there. That is the canal, that's the body of the uterus. So you can see here this is a subserosal fibroid. So fortunately, this type of a fibroid, you can easily see it. Why? Because it is slightly hypoechoic as compared to the rest of the uterus. So this is hypoechoic. So this is a subserosal fibroid. So this is another fibroid there. You can see that there's peripheral vascularity that you're seeing there. There's peripheral vascularity. So that's this one. So at times when you see blood flow inside a fibroid, it will mean that that fibroid is transformed into cancer. So at times fibroids can transform and become cancerous. So humanity or blood supply, you must query cancerous transformation. Do not just ignore that and comment it as a normal fibroid, because the gynecologist can just try to take it out when it's a cancer. So, the management of cancer is very different from these benign lesions. So again, if you look here, the uterus, you can see nicely here, we do have got a fibroid. So this one again is a subserosa fibroid, because you can see it's indenting the serosa of the uterus. So this one is the endometrial lining. So you can see going all the way, connecting the cervix there to the rest of the uterus. So there we are. We have got a subserosal fibroid around the isthmus of the uterus there. So here we have this is a fibroid that is attached to the rest of the uterus by a stalk again. So I've spoken about this. This is what is called a pedunculated fibroid. It's held by a stalk. So that's a pedunculated fibroid. So again here you can see this is another fibroid. So this is another fibroid there. So you can see all of that is a fibroid. So you must learn to appreciate and understand anatomy using different machines, because some machines have got a very good resolution, but some they don't have so good resolution. So you must be conversant using high-end machines and using the old machines, so that if you switch departments, you can still be competent in using these old machines. So you see here, this is another fibroid that is squarely masquerading. It's masquerading as a polyp. So there we have it. So this one at times it is very difficult to distinguish from a polyp, but you can see also that it's attached through a